Hello.
Avinash.
Uday boss, good evening.
Hi, good evening, Vijay. Good evening, everyone.
Good evening, sir. Good evening, all the dignitaries.
So as usual, I'm still in the operation theatre, but I am trying to attend whatever I can. Bits and pieces. Vijay, there's someone. Yeah, hi.
Good evening.
Good evening, everyone.
Yeah. Avinash, will we start with the meeting? Avinash?
2 minutes. 2 minutes only. We'll start at 7:05.
Okay. Sir join nurses झाले तर what? Yes. Okay.
वर्षा मॅडम मी बोलू का आपली मीटिंग चालू झाली?
ऍक्च्युली मी रेकॉर्डिंग स्टार्ट केलं होतं, बोला ना मॅम.
वर्षा स्टॉप द रेकॉर्डिंग.
मला सांगा आता. हे बघा मी शेअर स्क्रीन केलंय, हेच क्लिक करायचं ना अवनी. शेअर केलं. आता माझं स्लाइड शो मोड मध्ये फक्त जात नाहीये, त्याच्यासाठी काय करू बाळा?
इथं बघा स्टार्ट बिगिनिंग आहे फर्स्ट फाईलच्या खाली वरती इकडे त्याच्या बाजूला.
नाही मला सगळे ऑप्शन दिसतात मॅडम. स्लाइड शो कुठून चालू करायचं मला माहितीये.
क्लिक करा तिकडे. तिथे नाही मॅम, तिथे नाही. फर्स्ट नंबरला ऑप्शन करा क्लिक. डबल क्लिक करा ना मॅम.
झालंय. मला माझ्या कॉम्प्युटरवर दिसतोय स्लाइड शो, तेच तर सांगते मी तुम्हाला.
म्हणजे
नाही मला दिसते ग, मला फुल स्क्रीन दिसते.
म्हणजे तू पुढची स्लाइड करून बघ.
काय मला फुल स्क्रीन दिसतायत.
तू पुढची स्लाइड घे, आम्हाला दिसते का बघू पुढची स्लाइड.
घेतल्या ना, घेते मी.
आम्हाला नाही दिसत, आम्हाला पहिली स्लाइड दिसते.
हो का? मग का होत नाहीये तसं?
जरी डू नॉट नो तू आता वर्षाकडे पाठव. वी विल स्टार्ट द प्रोग्राम.
मी तसंच
ईमेलला कर. अजून तुझ्या
मला मेल पाठव.
वर्षा मॅडम, मंजिरी मॅडमची कोऑर्डिनेट करा.
येस मॅम.
आता स्लाइड्स.
Ultimately had a fatal hemorrhage, stroke 2 months later, and his death brought hypertension potential as
Madam, we will start the all participants are requested to mute their audio, please.
वर्षा मॅडम सगळ्यांना म्यूट करा प्लीज.
येस डन.
Good evening, everyone. We are really sorry for some technical delays. Respected Vice President, National ISA, Dr. Anjali Bure Madam. Respected dignitaries of Maharashtra State. Our moderators for today's session, Dr. Uday Gandhi and Dr. Vijay Shetty. Our speakers for today's session, Dr. Sheetal Dalal, Dr. Manjari Madnurkar, Dr. Deepak Borde and Dr. Samrat Madnaik, and all the members of Maharashtra State as well as from outside Maharashtra who have joined this webinar. A big welcome to you all. Today's webinar is going to be an interesting pros and cons sessions, and I'm really thankful to all the moderators as well as all the speakers for accepting the invitation in a first message only. Once we circulated today's flyers, we realized that the topics are so interesting because I got many messages on my personal WhatsApp that these are very practical topics, and so many times it creates dilemma in our anesthesia day-to-day practice whether to go ahead with this kind of cases or what are the risks involved in doing such cases if the patient has very high blood pressure. What is the exact meaning of diastolic grade 1 dysfunction, and what should we do if the cardiologist has written a diastolic dysfunction, and both these cases if they especially come for non-cardiac surgery. So let us hear from the faculties as well as the stalwart moderators today regarding both the pros and cons sessions, and the expert opinions from our moderators will definitely help us to give an exact idea or guideline for going ahead in such cases. May I request Dr. Anita Hede Madam to welcome Dr. Vijay Shetty Sir.
Thank you, Manisha Madam. And it is my proud privilege to welcome Dr. Vijay Shetty. Dr. Shetty, are you there?
Yes, madam. Thank you so much for the warm welcome.
Yeah, I would like to introduce Dr. Shetty in very few words. So everybody knows him. And Dr. Shetty has been the secretary of the Mumbai Anesthesia Society. And he is the executive member of the Indian College of Cardiac Anesthesia. But we know him mostly because he has been arranging these very popular meetings, the MASCON meetings, and we all have been attending them very regularly. He is very well known for him being the part of the first successful heart transplant team. And over the last 4 years, they have done more than 100 cardiac transplants. So we are very eager to listen to you, Dr. Shetty, about your comments on these topics. And with this very, very short introduction, over to you, Dr. Shetty. And let us take the program forward. I request Avinash. Avinash?
Yes, Dr. Sai sir is not there.
Okay.
It's okay then. Let me take this pleasure to introduce the next speaker, the next moderator for today's session, Dr. Uday Gandhi. I know Uday Gandhi right from my childhood because we used to stay in the same quarters, in medical quarters in Nagpur, and we both of us have we both of us had been to same school in Nagpur, that is the Hadasai school, and I remember Uday right from my childhood days and right from my school days. Welcome Uday to this platform of Maharashtra State Chapter ISA.
Thank you, Manisha.
Uday also doesn't need any introduction. He is consultant cardiac anesthesiologist, Hinduja and Lilavati Hospital, Mumbai. He is ex-secretary, presently treasurer and founder member, and association of, he is in charge of ACTA Mumbai at the moment, vice president of Indian Association of Cardiothoracic Anesthesiologists. He is a post-director for fellowship in cardiac anesthesia, organizing secretary for ACTA in Mumbai, that was held in Mumbai in 2014, and organizing chairperson for ACTACon in Goa in the year 2020. He has more than 10 publications in Index Journal. Welcome, Dr. Uday Gandhi.
Okay.
Thank you, Manisha.
Thank you, Manisha Madam. Now, it's my pleasure to introduce our faculty, today's faculty, Dr. Sheetal Dalal Madam. Madam is MBBS, MD Anesthesiology. She is Associate Professor, Department of Anesthesiology, Indira Gandhi Government Medical College and Hospital, Nagpur. She is recognized postgraduate teacher, MUHS Nashik since 2008. She is clinical coordinator, ISA National Task Force Fight Against COVID-19, IJA reviewer. She is also now at present GC member of Maharashtra State Chapter of ISA. He had many awards, individual at state and national level as Best President, Best Public Awareness Award, and Mrs. Sindhu Ingle Public Awareness Award. She was organizing secretary, ISACON Maharashtra 2021 in Nagpur, which happened last year. She had President Appreciation Award from state in 2021. In her tenure as a president and secretary of ISA Nagpur branch, the branch got many awards at national and state level, like Public Awareness Third Day, membership drive, Best City Branch Award. She is faculty at many conferences. She presented paper and posters at various national and state conferences. She had publication at national and international index journal as first author. She is instrumental in starting CPCR activity on mass scale and donated CPCR charts, ambo bag and this. Welcome, Sheetal Dalal madam.
Thank you, sir.
The one thing I would like to mention about Dr. Sheetal Dalal is that she has won maximum awards from as president as a president appreciation award, and maximum awards. I think there must be the highest number of awards from National ISA. And recently I had been to her house and I had seen a big almar, that big cupboard that has been full of various prizes and awards and various medals that has been there nicely placed in a nicely organized way. And I'm sure that Sheetal is going to need a big almari again or a big cupboard again to get many awards. Welcome, Sheetal, on this platform.
We witnessed the conference. That was a big success. In spite of the COVID, it was a online conference of Maharashtra State.
Thank you. Thank you, Avinash. Thank you, Sheetal. I think Samir is not able to log in because he is driving on his way home. So I take this opportunity to introduce Dr. Manjari. Dr. Manjari Madnurkar is the consultant private anesthesiologist in Nashik, and she is in charge of NAMCO Cancer Hospital in Nashik. She is at the moment governing council of Maharashtra, member of Maharashtra State Chapter ISA, doing private practice in Nashik, mainly onco anesthesia and obstetric and gynec surgery. But today she is involved with some cardiac debate on the cardiac topic, but it is for non-cardiac surgery. So I'm sure Manjari is going to give good justice to that topic. Welcome, Manjari madam. Welcome to the platform of Maharashtra State Chapter ISA. So let us begin with our today's debate. The first debate, the topic you all know, a patient who is hypertensive on regular treatment for hypertension, well-controlled hypertension, and now he comes to the OT and he has high blood pressure. Whether to proceed for such case or not. Yes, Dr. Sheetal wants to proceed even if the patient has high blood pressure. Let's listen from Dr. Sheetal Dalal about her points in favor of proceeding for such kind of patient who is having high blood pressure. Dr. Sheetal madam.
Thank you, ma'am. Respected President, Maharashtra State Chapter, Dr. Manisha Katikar Madam, Vice President, National, Dr. Anjali Bhure Madam, respected Chairperson, Dr. Shetty Sir and Gandhi Sir, and all my delegates and good friends. A very good evening to all of you. So the organizer has kept this topic, that's mean 50% there are chances that we have to proceed such kind of patient if this patient has elevated BP in OR. So as we know, we are well versed with the Arjuna's dilemma at Kurukshetra. So my dilemma is with such patient when I enter into the OT and with elevated blood pressure. So as working as an institution, I have to play three roles: a clinician, a teacher, and administrative too. And my PG should not got this message that anytime we can cancel the case or anytime we can proceed at any situation. And for the administration, pressure is always there and we have to justify if I cancel the case. So the Arjuna's dilemma is clear by the Bhagavad Gita by Sri Krishna, Lord Sri Krishna. And of course, mine is Miller's anesthesia and the literature which is available on this topic. There is no conflict of interest. So really, the hypertension is a cause of cancellation of elective surgery on the day of surgery. Yes, audit which is presented in 2019, a 5-year audit revealed that hypertension as a primary result for the cancellation was only 0.37% of total cancellation and 12.6% of total anesthesia-based. Another study by our own Rakesh Garg sir that the most cancellation in OT were due to the high blood pressure. So what will happen if this the surgery gets cancelled, especially on the hospital resources? The cancellation of scheduled operation is a major cause of insufficient use of operating room time and waste of resources.
Sorry to bother you. Sorry to interrupt, Sheetal madam. Are the slides moving? Because I don't see the slides moving.
Yes, sir. It is moving.
All right. I'm sorry. Then it's something on my side. Somebody's written there. The slides are not moving.
No, Sheetal, we are not able. Your slides are not.
They are not moving.
Yes, yes.
It is moving
Yes.
on my side.
Okay,
Okay.
no, Sheetal, you again share again.
Okay.
Yes, it's now moving. Hello.
Now it is moving, Sheetal madam.
Yeah.
Yes.
Now we can see the 6th slide. Yeah.
You are now
Okay.
on sixth. Yes,
And
sixth slide.
you make it slideshow so that it will be easy for
I have.
us.
Yes, please.
Okay. Okay. Huh.
Yes, yes.
So delaying the surgery may be justified if the target organ damage exists, then can be improved by such delay. So it is very potentially stressful with the depressing effect and costly to the patient in terms of working days lost and disruption of progress. So as per the hypertension and recent classification is concerned, it is very given in our textbooks. So what are the perioperative concern? The postponement of planned surgery, and if surgery does proceed.
It is not moving. Slides are not moving. You are now.
Full screen and this is a 7th slide.
Yes, it is. We are watching six number.
Sheetal, you again share your screen. Again do that. Share again.
Abhi, now it is seen.
Yes, there you are now. There you are now. Yes.
Now
नाही आता तू पुढची स्लाइड आधी करून बघ.
नाही आता माझ्याकडनं बंद झालं मॅडम. 1 मिनिट.
नाही मूव करून बघा मॅडम.
आता आलं का?
नाही आता स्क्रीन शेअर झालेली नाही अजून. आता आलं तुम्ही थोडेसे मूव करून बघा.
6th स्लाइड दिसते आता. स्क्रॉल डाऊन करून बघा.
माग नाही
पुढची नाही दिसते काय?
बापरे, मी तुम्हाला हे पाठवू का व्हॉट्सअप?
यू क्लिक ऑन द स्लाइड्स.
1 मिनिट. नेक्स्ट.
किती करायला पाहिजे?
नाउ इट इज सीन.
No, ma'am. No.
एक काम कर शीतल, you now stop sharing. Share your screen again. Share the screen. Yeah.
मॅडम स्लाइड शो ओपन करा आणि मग शेअर करा.
Open slideshow first.
First you open the slide show.
स्लाइड शो ओपन आहे माझा.
मॅडम नाहीच होते ते. प्रॉब्लेम समवेअर फ्रॉम देअर साइड मे बी.
नाही मंजिरी. No.
Varsha, are you there? Varsha?
Yes, sir.
What is the problem?
I think this system problem, sir. Hear me? Yes, now visible.
It's visible, but it's not moving.
It is not moving.
Just click arrow.
तर मी तुम्हाला पाठवू का अविनाश सर?
नाही वर्षाला पाठवा. मी वर्षाचा तुम्हाला नंबर पाठवतो.
नाही ग्रुपवर टाकलाय वर्षाचा मेल.
मी ग्रुपवरच टाकू का?
नाही
वर्षाला मेल कर. शीतल वर्षाला मेल कर.
मेल करायला आता ते पूर्ण ऍड व्हायला वेळ लागेल. मी व्हॉट्सअप करू का त्यांना?
हा कर. वर्षाला व्हॉट्सअप कर. वर्षा तुझ्या व्हॉट्सअप वर येतात स्लाइड.
ओके मॅम.
मंजिरी तू पण वर्षाच्या व्हॉट्सअप वर स्लाइड्स कर.
ऑलरेडी केलं. मेल केला वर्षाला.
मंजिरीचं होऊ देता का तोपर्यंत?
Madam, can you go to the next slide now? Possible? You can see your slide.
वर्षाचा नंबर पाठवा ना.
सांगू का मॅडम?
सर मी तुम्हाला पाठवते. भोसले सर तुम्ही पाठवाल का त्यांना?
मॅडम ग्रुपवर पाठवा. मी पाठवते. मेल करते मी वर्षाला. तुम्ही फक्त
ग्रुपवर पाठवू का? हो मी पाठवते.
मी करते.
पाठवलं.
मी लगेच करते मेल तिला. मी जस्ट केलाय थोड्या वेळापूर्वी.
परत एकदा ट्राय करून बघते तो परत.
मी करते तिला मेल करते आता.
Sheetal madam, on the top right there is a view screen. View, that 9 dots are there. Just press that and see what screen are you?
Right corner.
Right top corner मध्ये.
Right top corner.
Top ला एक buttons आहेत ना, 9 buttons. View मुलीला तिकडे.
नाही माझ्या इथे नाही. राईट टॉप कॉर्नर ना हे इथे व्ह्यू.
हां. Yeah. So just see what screen are you using?
फुल स्क्रीन. करू का आता? पाहतो करून बघते आता.
अजून ओके फुल स्क्रीन करा.
नाही ते समोर नाही चाललं.
तुम्हाला दिसत नाही आणि तुम्ही नेक्स्ट स्लाइड प्रेस
नेक्स्ट स्लाइड मला चाललं नाही.
तुम्हाला दिसत नाही ना ते. ओके देन अगेन गो टू द व्ह्यू अँड नाउ गो टू द व्ह्यू अगेन.
इनी सुरू केला बहुतेक.
आता मॅडम स्क्रोल करा.
नाही आता वर्षाने चालू.
वर्षाने हे केलं.
दिसत नाही आहे तिचं.
येईल
नाही ते अजून व्ह्यूइंग वर लोड होते. एक 2 मिनिट.
You can stop sharing ना शीतल मॅडम.
Now visible my screen?
No.
मॅडम वर्षा नाहीये. स्क्रीन दिसते पण हा काही दिसत नाहीये.
Now?
हो. याच्या आधीच का ना. ओके नेक्स्ट. आता मला नेक्स्ट म्हणावं लागेल.
शीतल मला वाटतं आधी सुरुवातीपासून घेतेस का? कारण
ठीक आहे चालेल.
8 मिनिटाचंच आहे. प्लीज.
Varsha, stop your recording. We'll have to edit the whole video right from the beginning. Madla part kadun takun. Stop recording and again restart recording.
Okay, ma'am.
We are extremely sorry for all the technical glitches. I request Dr. Sheetal madam to share the screen and start her presentation. Varsha, please help her.
Varsha, please mute others.
Yes, ma'am, you can start. Sheetal, ma'am.
We can't see the screen, Varsha.
Now?
Yes.
ओके.
तू स्क्रोल करून बघ.
हो नेक्स्ट करून पहा. ओके नेक्स्ट. ओके.
Yes.
I have to say so many next. Okay.
Yes.
And then you can't help it. Chala, record start.
Okay. First line. Sorry for inconvenience. The organizer has kept this topic, that is when controlled hypertension for elective surgery gets elevated BP in OR, whether to proceed or not to proceed. That's mean there is 50% chances that we should proceed. Next slide, please. So we all are versed with the Arjuna's dilemma at Kurukshetra, whether to proceed or not. My dilemma when comes in OT with elevated blood pressure. As working in the institution, there are 3 roles which I have to play. One is a teacher, one is a clinician, and one is administrator. So there is always administrative pressure is there, and my PG should not go with the wrong concept that at any time we can cancel the case, at any time we can proceed the case, and we have to justify the cancellation of this case. Next slide, please. So Arjuna's dilemma is cleared by the Lord Krishna by Bhagavad Gita. It's a Miller anesthesia. Next slide, please. So is really the hypertension is cause for next. You have to click more. Really hypertension cause of cancellation of the surgery? Yes. The 5-year audit revealed hypertension as a primary reason for the cancellation of surgery of the total cancellation and 12.6% of total anesthesia cancellation. Next, article by Rakesh Garg also reveals. Next, there is a most cancellation are due to the hypertension. So what are the effects of cancellation on the resources? So there is a major cause of insufficient use of operating room time and waste of resources. It is also the potential stressful with the depressing effect and costly to the patient in terms of working days loss and disruption of daily life. Next. So delaying surgery may be justified if target organ damage exists, then can be improved by such delay. Next. So this is the definition of hypertension and recent classification. And today's topic is mainly the stage 1 and stage 2. Next. Next, ma'am. So what are the perioperative concern? Is the plan, if the surgery does proceed, what would be the expected outcome of the patient's perioperative journey? So it is clear whether elevated blood pressure constitutes an increased perioperative risk, and yet uncontrolled hypertension constitutes a major reason for cancellation of elective surgery. So a thorough understanding of the disease process, its influence on perioperative outcomes, and knowledge of base evidence and practice is imperative to facilitate decision making and optimize the. So what is the literature? So the Miller and the Stolting also says that the surgery should be proceed if the diastolic blood pressure is less than 110 mm of Hg and with systolic blood pressure 180. Ma'am, please. Next. And if the blood pressure is diastolic is more than 115 and systolic more than 200, so it should be cancelled. Next. Same with Stolting. Next slide, please. So as per as guidelines, the guidelines released by Association of Anesthetic and British Hypertension Society in 2016, the patient with primary care setting were referred for elective surgery with an systolic BP of less than 160 mm of Hg and diastolic BP less than 100 mm of Hg. Once the patient has entered the secondary care pathway, the elective surgery should proceed if the systolic BP is below 180 and diastolic BP is less than 110. A significant reduction of number in preoperative cancellation due to the hypertension alone from 2013 to 2018. So in 2017, again the American College of Cardiology and American Heart Association come with the guideline at systolic BP 180 mm of Hg, proceed with the surgery but very cautiously, and the cancellation of surgery should be done if BP more than 200 mm of Hg systolic. Next. So there are a number of articles which also reveals that there is little benefit to be obtained by deferring or cancelling elective surgery if blood pressure is less than 180 to 110. Next. So here is a meta-analysis. Again, it revealed the same thing. Next. Next slide, please. So, however, there is no universally accepted guidelines stating that the level of blood pressure at which elective surgery should be cancelled. Increased complication, including cardiac as well as the neurological complication and renal failure, have been reported if the preoperative diastolic pressure is 110 or higher. So, it has been recommended to cancel the elective surgery if systolic blood pressure is more than 180 and diastolic blood pressure is more than 110. Next. Next slide, please. So here again the meta-analysis which recommend that the anesthesia and surgery not to be cancelled if blood pressure lower than 180 to 110. Next. So this there should be a balance between the risk and benefits. So the requires weighing of the situation and should go ahead only if benefits more than the delay for optimization. Next. Next slide. So what are the risks? Controlled hypertension versus controlled hypertension. My topic concerned the controlled hypertension. Next. So there are different articles which say that the cardiac and the pericardiac complications and neurocomplications are more with uncontrolled hypertension rather than the poorly controlled hypertension. So a patient without evidence of significant coexisting cardiovascular disease can be taken up surgery even with the elevated blood pressure. Next slide, please. So while a preoperative history of uncontrolled hypertension is strongly associated with the perioperative cardiovascular death and renal dysfunction and vascular disease. Next, so what are the consequences? Difference between the controlled hypertension and uncontrolled hypertension in respect to surgery. So sympathetic response during induction of anesthesia may be pronounced in patient with uncontrolled hypertension, which we laser with controlled hypertension. Then we are giving spinal or epidural can cause unpredictable and profound artery hypertension in poorly controlled hypertension, and in controlled hypertension more predictable response. And the patient with elective surgery, already the cardiac or renal screening is done, and we are very well versed with the patient condition even if the BP elevates in OR. And there are less than 10% chances of elevated BP episode and cardiac neurocomplication if the patient is already controlled. Next. So hypertension is associated with the adverse perioperative outcomes, that is increased cardiovascular liability and greatest risk of perioperative complication, mostly with uncontrolled hypertension rather than the controlled hypertension. Next. So next slide, please. Next slide. So my topic includes controlled hypertension. So pre-anesthetic fitness is already given for elective surgery. As compared to severely hypertensive patient, mild to moderate hypertension is now associated with the perioperative cardiac complication. Now BP elevates in OR. What are the possible causes? Next. Next slide. So the common causes of elevated BP in OR is anxiety, white coat hypertension, OT fear, pain, and missed morning dose of hypertensive, which is most commonly seen with the patients. Next. Next slide. Hello. So there are two papers which also said that physician must not take the consideration this gap before proceed to the therapeutic handling of the patient with increased BP levels or postponing the patient. Next. Again, next. So these patients are usually present with elevated BP on the day of surgery due to the anxiety. Next slide, which can be safely managed with the administration of sedatives and anxiolysis. Next slide. So general practitioner, perioperative physician, anesthetist, and surgeon are often left to rely on their own clinical judgment regarding the management of hypertensive patient, leading to the gross variation practice, not only in between the regions, but also department. So there is always difference between institutional versus private practice too. It is very easy to cancel the patient at institutional level, but as far as private practice, I don't think so. So with the clinical experience, expertise, and evaluation in the resources, drugs, and monitoring in managing such patients, we can definitely proceed. But how? Next. Next. So patient safety should be taken. If systolic BP is more than 180 and 110, and there is no prior history of hypertension, even the BP is same, after taking the medication, the surgery should be postponed. Before that, it should be given to intravenous antihypertensive dose should be administered. The small dose of anxiolytics such as midazolam could be administered, or Dexmed can help. But it is very important the order of cases should be considered to afford this agent time to work prior to inducing anesthesia. Next. Next slide. So it is again, it is very important, that is risk of cerebral hypoperfusion and even ischemia can occur should perfusion pressure decrease during the anesthesia admission. So strict care should be ensured for perioperative stability rather than the preoperative hypertension. The perioperative use of beta blockers and alpha-2 agonists has been shown to maintain perioperative hemodynamic stability. Next. Next slide. So how we can proceed? So there is a maximum use of, you can use regional anesthesia. Whenever applicable, combination of general anesthesia and regional. Pre-medication, you can use Alprax and diazepam. Then there is a roles of alpha-2 agonists like clonidine and dexmetadine. Then midazolam in pre-induction hypertension. Then liberal use of opioids attenuate to response to laryngoscopy and intubation and rescue amount of induction dose. Ethomidate preferably the induction agent. Next slide. So perform smooth and gentle fast laryngoscopy and intubation. Spraying of cords no longer recommended. IV Chilidocaine less effective as compared to beta blocker and high dose opioids. Invasive or non-invasive monitoring depending on the type of surgery. Local anesthetic block and infiltration, deeper extubation and adequate pain relief. And intraoperative use of anti-G labetalol after ruling out other causes like inadequate ventilation, inadequate analgesia, and depth of anesthesia and drug errors. Next slide. Next slide, please. So, why to fear when we have so much there is a greater understanding of the disease process and the fact that we have better drugs and monitors at our disposal to treat and evaluate the effect has pushed continuously and gave confidence to at what blood pressure cancellation of elective or non-cardiac surgery should be done or proceeded. So it is not merely the elevated blood pressure values, but what these values do to organs is what constitutes a risk. So it is very important to be careful rather than fearful, as care improves patients' outcome, whereas fear results in unnecessarily delays and case cancellation. And anesthesiologists have so much shastra astra. So why to fear? Next slide, please. Next slide. So this is a slide by our respected past president of Maharashtra State chapter, Dr. Shakil Momin, and the final truth is रणभूमि पे लेके जाने वाला, सही राह दिखाने वाला, विपत्ति के समय काम आने वाला एकमेव सखा साथी श्री कृष्ण एनास्थेसियोलॉजिस्ट है. So again, the ISA logo itself revealed that we have the knowledge and skill like mermaid, so that we can sail this patient from the stormy sea. So go to proceed for the surgery with 3E. That is experience, expertise, and evaluation in resources. Thank you, sir. Sorry for interruption.
Thank you. Thank you.
Thank you, Sheetal madam. It was really excellent presentation. And the last slide was excellent. It was really an excellent slide. So let's hear, Manjari wants to say something else. Yeah. Manjari wants to say something else. She doesn't want to go ahead with the case. She wants to wait. So let's listen from her. Manjari?
Yes, madam.
Yeah, please.
Varsha, will you please share my slides? Please bear with me. I have to say next for every time I have to change the slide because there is some technical issue.
Yes, we're not keeping pace with Sheetal madam.
Now visible?
Yeah. No, not visible yet. We are still seeing Sheetal ma'am's slides.
Yes, Varsha.
Yes.
Good evening, everybody, and all the dignitaries of Maharashtra State ISA chapter office bearers. And thank you very much for giving me chance to be part of this academic event. Dr. Sheetal madam has already shared so many things. So I have very few things to tell, but I am going to tell few opposite things. It may seem it is a debate, but technically I feel after listening to her, there is a consensus actually. So let us see what others feel about it. So let us see some interesting history about hypertension. It is surprising that only few decades ago, hypertension was considered an essential malady and not a treatable condition. An isolated systolic hypertension was considered treatable until 1991 when SHAPE study was completed, and it showed the tremendous benefit of treating systolic blood pressure. President Franklin Roosevelt was given a clean bill of health by his physician when his BP was 220/120. And he ultimately had a fatal hemorrhagic stroke 2 months later, and his death brought hypertension's potential as a deadly malady to the limelight. Next slide, please, Varsha. So Sprague was first to identify the association between hypertension and perioperative cardiac risk in 1929. Later on in 1966, Dingley recommended that patients presenting for anesthesia and surgery should, if possible, undergo autonomic testing before their operation. I still remember in my PG days, we used to do some part of it. Next slide. Next slide, Varsha. These recommendations were overtaken by the work of Priest Roberts and colleagues, who published a series of studies on the interaction between hypertension and anesthesia. Sheetal madam has quoted few of these studies. Next slide, Varsha. This is a very old study of 1971, and the authors reported that untreated hypertensive patients had a greater decrease in arterial pressure at induction of anesthesia. They were more prone to intraoperative myocardial ischemia. And on the basis of these findings, the authors recommended that whenever possible, hypertensive patients should have anesthesia and surgery deferred to allow their hypertension to be treated. And this recommendation led to a major change in anesthetic practice and to the modern perception that whenever possible, untreated hypertensive should not be subjected to elective anesthesia and surgery without first treating their arterial pressure. So this is an old study of 1971. Now let us see what is the recent literature. This is a recent literature of 2021, and this is a classification by American Heart Association and European Society of Cardiology. The European Society accepts slightly higher levels than the American Society, but both have consensus that grade 3 is more than 180 by 110, and grade 1 is 130 to 139 by 80 to 89, and grade 2 is more than 140 by 90 by American standards, and slightly higher standards in European Society. Next slide, Varsha. So what are the reasons? We have already seen. Main reason is anxiety, treated but inadequately controlled blood pressure. As madam said, it is the elective surgery. So most of the patients have been seen by physician or anesthetist, and their hypertension has been taken care of. So most of the time they are treated for hypertension, but they have forgotten to take, previous slide, Varsha, forgotten to take antihypertensive drugs on the day of surgery. And very rarely, the cause can be undiagnosed pheochromocytoma, preeclampsia, aortic dissection. These are very rare causes, but you cannot rule out these causes. Next slide. So there is a real dilemma what to do, whether to postpone or to continue. Next slide, Varsha. Next slide, please. Next slide. So what do we do then? There are very simple guidelines. So what should we do? We should use appropriate technique to measure blood pressure, use appropriate size cuff. We should palpate the pulse manually, make manual measurement if there is an irregular rhythm, and repeat the blood pressure reading after 1 minute interval. And you should take 3 readings and take the lowest of these 3 readings as a baseline and measure blood pressure in another arm. These are the guidelines by British and Ireland Society of Hypertension. Next slide, Varsha. So hypertension constitutes a major reason for cancellation of elective surgery. And there are 2 main concerns: whether postponing the case, whether it will help in treating the hypertension, or if surgery proceeds, what should we expect as an outcome of patient's perioperative journey. Next slide. So why we are so much concerned about hypertension? Is it merely the number of blood pressure that is important? Varsha, previous slide, please. Yeah, it is not the number. What is more important is what this hypertension does to our body. Most of the hypertensive patients are likely to have left ventricular hypertrophy, diastolic dysfunction, heart failure, coronary artery disease. They are likely to have hypertensive encephalopathy if blood pressure is very severe, retinopathy, renal problems, and the presence and severity of this target organ damage is an important aspect of the preoperative assessment of these patients. And presence of such damage is an indicator of the severity of hypertension. Next slide, Varsha. Next slide. So what are the concerns for anesthesiologists? As madam rightly said, exaggerated hypotension after induction of anesthesia, especially for those who are on ACE inhibitors, excessive pressure response to stresses such as laryngoscopy, intubation, surgical incision and extubation, and cerebral and renal autoregulation is shifted to the higher side. And brain and kidney are more particularly prone to hypotension if blood pressure is lowered too rapidly. And these hypertensive episodes are usually associated with arrhythmias and or myocardial ischemia. There is a risk of cerebrovascular accident if there is a hypo or hypertension. And these patients are more prone to hypertensive response even in post-op period for bladder distension, inadequate pain relief, etc. Next slide, Varsha. So what does the guidelines suggest then? There is a consensus in all textbooks or recent guidelines that stage 3 hypertension, that is blood pressure of more than 180 by 110, there is evidence that significant increased risk of target organ damage is there. There is increased incidence of ECG abnormalities, increased incidence of post-operative myocardial ischemia. And they are at risk of dangerous hypertensive crisis, like causing intracranial hemorrhage, acute left ventricular failure, life-threatening ventricular arrhythmias, or renal failure. And on the basis of these data, it is appropriate to defer anesthesia and surgery wherever possible in patients with arterial pressure consistent with stage 3 hypertension. So there is no dilemma about stage 3 hypertension basically. Let us see what is next in stage 2 hypertension. Next slide, Varsha. So stage 2 is a dicey scene whether to postpone or not to postpone. There is a real dilemma here. And postponing the surgery and preoperative treatment is recommended if patient suffers from target organ involvement like coronary artery disease, impaired renal function, and cerebrovascular disease. Next slide. And stage 1, for those with mild hypertension, surgery may continue. Next slide. Next slide. As we have seen in stage 1 and stage 2, if there is no target organ involvement, we can continue with surgery only if there is a big but that the care should be taken to ensure perioperative cardiac stability. Then few times invasive arterial pressure monitoring is indicated for major procedures. And blood pressure has to be maintained within the range of 20% of the baseline. And this monitoring should continue in the post-operative period until it is clear that patient is cardiovascularly stable. It is possible to maintain the blood pressure in particular range in operation theatre, but not always possible to maintain that in next 72 hours, which is very crucial. So it is, the evidence says that myocardial ischemia never has been seen during anesthesia. It is most of the time during first 72 hours after major surgery. So this is a crucial time and it is difficult for anesthetists to maintain those 72 hours. We can very well maintain in operation theatre and manage the patient in a high dependency area in the immediate post-op period. And IV antihypertensive drug should be immediately available to treat hypertensive crisis. Next. So these guidelines assume that there is an easy access to non-invasive cardiac testing, coronary angiography, and revascularization before surgery. And these guidelines may be difficult to apply in settings where these resources are limited. Therefore, the guidelines should be modified for local use so we could give optimal medical treatment to our patients. Next. So our approach should be to modify guidelines according to the circumstances and type of surgery. If ICU care, easy access to non-invasive cardiac testing, angiography, angioplasty is available, then only it is wise to continue with surgery. And if not, it is better to postpone the surgery specifically for stage 2 and stage 3. Next. It is not merely this elevated blood pressure values, but what these values do to organ is what constitutes the risk. And we must consider each patient's overall cardiac risk to make decision whether to continue with surgery or to postpone. So as Madam said, it is important not to be fearful, but at the same time, it is very important to be careful also. Next. And main important issue we doctors are facing nowadays. For a person like me who is doing the case alone in a private setup, even though Nasik is a well-developed city with very good amenities in the hospital available, still if you are doing it alone, you have to face the consequences most of the time alone till the help arises. So it is difficult even to defend in court if any untoward event happens in a planned surgery. So as a privately practicing anesthetist doing the cases alone, I know that it is very, very difficult to postpone the case by just due to elevated blood pressure readings, but it is always better to be safe than sorry. Thank you. Next slide, Varsha. Thank you very much.
Varsha, stop sharing the screen. Yes, excellent presentation, Manjari. And we are also in dilemma now. So let's listen from Sheetal again, what she has to say over what you have explained, that I'm practicing in Nasik and I don't want to go ahead with such kind of cases who has high blood pressure more than 170 by 110. So Sheetal, please.
Hello, actually my topic has already mentioned the blood pressure is well controlled. That means patient is on hypertensive and we as anesthesiologists, we have given already a preoperative fitness. So on the OT, there is a elevated BP. So maybe we are already very well versed with the organ damage and we have given the fitness. After that, the patient elevated on BP, the most common cause is anxiety and as well as the patient has not taking the morning dose. So we can take the patient after one patient and give the morning dose. We can first give anxiolysis and see whether blood pressure comes or not. Again, the newly drugs, you use drug like Dexmed. It is a very good drug for pre-op, which causes sedation, anxiolysis, as well as anesthesia, analgesia. And we have such a good antihypertensive drug like IV, like labetalol. It is very good antihypertensive. And we have good monitoring also. So we can and it depends upon the personal experience, madam, expertise and the resources which is available at you, whether it is private practice and institutional level. So if the blood pressure is below 180, 110 and it comes 20% comes preoperatively, we can proceed for surgery. But patient's prime importance should be given to the patient safety.
Yeah.
Thank you.
Thank you, Sheetal. So Manjari, now you have to defend. You have to.
Yeah. What Madam said is our patients are properly evaluated. They are treated for hypertension. They are evaluated for target organ damage. That is very much true. But what is important is patient has shown the response to anxiety. And that response is hypertension. Okay, it is similar to white coat hypertension, like patient is now having normal tension at home and hypertension seen at the doctor's visit. So it is same. Patient is having anxiety, he is exhibiting hypertensive response in the operation theater. So it is very much likely to have same response in ICU and post-operative period. The same response he is likely to have to pain, because whatever analgesia you give, you may be 95% effective, but there is a still 5% chance that you are going to have a post-operative pain, especially for major anesthetics, major surgeries. So this response is bound to occur in a post-operative period also. And that is a very crucial period when myocardial ischemia occurs and myocardial infarction. It is very rarely seen during anesthesia. When it is seen is during post-operative recovery period of 72 hours. And surgeons are very hesitant to start Clexane or whatever hemolytic agents in at least in first 42 hours. So it is a crucial time and patient have demonstrated that he is having hypertensive response. So why to take risk? We can start few more antihypertensive, few new drugs we can add or whatever, and then do it after 8 days. So because life is precious, there is no point in giving importance to cost of whatever working days and depression. More important is life and safety of both ourselves and patient.
Thank you, Manjari. It's nice to listen to both of you. Both of you have strongly recommended about that one is very given expert opinions regarding whether to go ahead or not to go ahead. But we have to come to some consensus at the end, and we have expert moderators with us and to guide us regarding this issue. So may I request Dr. Vijay Shetty? Dr. Vijay Shetty, sir, please.
Yeah, thank you, madam, for putting me in this seat, because what I hope that I just like to have a few comments before I say anything. One is that it was an excellent debate or topic discussed between both the speakers, and both the speakers have emotionally as well as with a lot of good clinical points put it across. Now, my dilemma is that what do the delegates take it from here? Like you correctly said, both of them have forcefully put up the points. Now, one of the most important things is that the BP that you're seeing on the OT is not the correct BP. The BP that you're monitored correctly in the preoperative is the correct BP. So like both the speakers very rightly said, if the BP has been correctly taken, which is the actually missing link here, what is the patient's normal BP? If I am not aware of the patient's normal BP, then what I'm doing in the OT is the first reading that I've taken. So I hope that this really brings to the point that in your hospital or hospitals where you're working, there is a good system of taking the accurate BP. Even if this much we take from this lecture or this talk, I think this CME or has been successful, because that is a primary lacuna in this. The second point I want to make is that, very correctly said by both the speakers, identifying a high BP is an enormous responsibility on the anesthetist, because it gives a chance to detect reversible causes of hypertension. It may be a pheochromocytoma or a thyrotoxicosis. And these are errors which even the physician misses many times. So you will find in your practice also, you would at least detect 2 or 3 patients in whom you have detected a irreversible cause. And even that is a big responsibility for us. One of the things that Dr. Sheetal said, I don't agree. One of the European guidelines said that you can go ahead with 180 systolic. Definitely not, I think, because it comes in the definition of a hypertensive crisis. Just like Dr. Manjari said, that if you induce a patient with 180 systolic BP, and definitely there is hardly anybody who can save you probably, or you might have to doctor your note to say that the BP was not 180. But going ahead with a BP of 180, what happens when you are dealing with this patient with perioperative? You can imagine you already started discussing this BP is high, and then you do a MDT, you talk to the relatives. Everybody gets involved in the idea that the BP is already high. So any complication happens, it will be blamed, whether it's surgical or otherwise, it will be blamed on that very well discussed hypertensive things that you discussed in the perioperative period. So I think that is one thing that Dr. Manjari correctly said. On the other hand, Dr. Manjari said that if a cath lab and rest of things are available, we can go ahead. Certainly not. I would not depend on the cath lab for bailing me out in a perioperative event, because I've already operated this patient. And like you said, in the first 24 to 72 hours, if an event were to occur, no cath lab is going to save me, because I already have a big incision, and all those blood thinners and angioplasties cannot be offered to this. So this discussion has to happen in the perioperative period, that we are going ahead with the risk, which is we have assessed. We are confident of being able to control the BP in this first 24 to 72 hours. But there is a chance that the BP might not be controlled, and you will have these events of hypertension. What we normally forget is that hypertension is not actually the biggest problem. The biggest problem is the hypertension that occurs in patients who have uncontrolled hypertension. Both the speakers very amply said that if your patient is well monitored, has a controlled BP, if your BP is high on the table, does not matter. Probably it will all be quite good. But if a patient is a first time detected near about hypertensive crisis level of BP in the operation theater, certainly you should postpone unless the patient is an emergency. So if you have documentation that it's an urgent or a limb or a life-saving surgery, you would definitely go ahead. So I think both speakers made excellent points about that major organ dysfunctions related to hypertension being the real crux of the matter. Like if you operate on somebody with a BP of 180, 200, nothing acute is going to happen. But what your end organ damage tells you is that a patient has suffering from a severe hypertension, most probably uncontrolled, and this patient is going to give you trouble in the intraoperative and the post-operative case, this as well. And the one thing that was not discussed, and I think it should have been, and it is very difficult to discuss, is also, supposing Dr. Manjari goes ahead, then what is your, Dr. Sheetal goes ahead, then what are the targets that you're going to tell yourself? That I am going to let the BP fall by 20 to 30% and not let it rise anymore. That is the kind of target that you're, and those are very tough and stiff targets about not letting hypotension come because your organs ischemia is prevented, or hypertensive response comes so that bleeding is avoided. So these are a few of the points that I wanted to make. But overall, I think if the delegates have been paying attention, they would have picked up a lot of important points. For example, one of the smallest points that she said was about bladder distension. One of the most unappreciated points about perioperative hypertension. So those are excellent points, I think. So unless the one more point that I think we should highlight is that there is no merit in starting an urgent beta blocker correction and then operating on the same day. Very correctly, Dr. Manjari said that if you are going to postpone for a few days. If you cannot postpone for a few days, there is no point in doing a urgent beta blocker addition or a lateral infusion and then going ahead, because your chances of hypotension increases, and thereby you put the patient at more risk. And finally, I want to thank Dr. Varsha, because she did an excellent job of rescuing this meeting. I hope she didn't have any hypertension of her own. So thank you, ma'am, for this. I'll stop here.
Thank you, sir. Thank you.
Thank you, sir.
It was excellent, valuable opinion from you, Dr. Vijay Shetty. Let's listen from Dr. Uday Gandhi, what he wants to say on this issue. Dr. Uday, please.
Yeah. Sorry, Manisha. As I told you, I'm still in the operation theater. Just few points. I think most of it is discussed already. Vijay also said few points which are very valid. Just one important significant point in this is when we are thinking about hypertension, there are two hypertensions. One is the systolic hypertension, other is diastolic hypertension. Now, systolic hypertension is one which probably is because of anxiety, as everyone was saying, which is correct, and can probably be managed, and we can go ahead with the surgery. But diastolic hypertension is one which is definitely pathologic, and we should be worried about it. Because pathology, diastolic hypertension is always something to do with heart conditions. So this is one simple point, that if patient is having systolic and diastolic both hypertension, then definitely we need to postpone the surgery. Numbers doesn't matter whether it is 120, 180, 110. Everyone has different things in mind and different guidelines. The guidelines also keep changing. Second thing is, we should also think about, before postponing any surgery for hypertension, what surgery it is. If we expect a big blood loss or it's a vascular surgery, then definitely we should wait and not go ahead with the surgery. If it's a very small surgery where we don't expect any blood loss, then probably we can control blood pressure and go ahead with the surgery. Third point is, if patient is a hypertensive, we need to accept a little higher blood pressures, because if you try and get blood pressures too low, patients will have end organ failures. So if a patient is already on hypertensive therapy, antihypertensive therapy, and is maintaining, as Vijay said, what is important is what was the blood pressure before surgery or before a patient came to the operation theater. That is more important. We try and get blood pressure too low, his urine output definitely will go down, his kidney will suffer, all other organs will suffer. So these 3 points, I think we should be very careful about. Rest, I think both the speakers were excellent, and all the points that we discussed were very relevant.
Thank you so much, Dr. Uday Gandhi. Excellent presentation by both the speakers, and very correct and nice and great inputs from both the moderators. There are many questions in the chat box at the moment on this first debate, but I think we'll take all the questions at the end, as both our next speakers are also waiting for their presentation. May I request I think Dr. Hemant Shinde has not joined. Will you introduce Dr. Deepak Borde, sir? Avinash sir, will you introduce Dr. Deepak Borde?
Yes. It is not there. Okay. Varsha, please slide.
Yeah, for the next presentation, the topic is, Varsha, please, in the meantime, please share the screen, share the slide of Dr. Deepak Borde. The topic for next debate is grade 1 diastolic dysfunction. Is it overdiagnosed? And if it is yes, if it is overdiagnosed, what should be done by the anesthesiologist who sees the report as grade 1 diastolic dysfunction in the 2D echo report? So let's listen from Dr. Deepak Borde and Dr. Samrat Madnaik, their views on this, and then from the moderators regarding the expert opinion. Varsha madam, can you share the screen of
which one, ma'am?
Dr. Deepak Borde?
Yes.
Dr. Deepak Borde, sir, is consultant cardiac anesthesia at Ozone Anesthesia Group, Aurangabad. Sir done his MD from LTM Medical College and Sion Hospital, Mumbai. Then he done fellowship in cardiac anesthesia from Jayadeva Institute, Bangalore. He done fellowship in transesophageal echocardiography from India and European board. He passed advanced PT exam by National Board of Echocardiography USA in 2019. He is the winner of prestigious Janak Mehta Best Paper Award in ICTA Kochi in 2013, ICTA Mumbai 2014, and Chennai 2016. He is on editorial board of Anesthesia Annals of Cardiac Anesthesia and ICTA Echo Library, guest reviewer of Journal of Cardiothoracic Vascular Anesthesia. He published 22 original. Varsha, I could not see the slide. Okay. Published 22 original articles in Journal of Cardiothoracic and Vascular Anesthesia, Annals of Cardiac Anesthesia, and Indian Journals of Anesthesia. He conducted 2 surveys on practice pattern of esophageal echocardiography and CPB at national level, which are published in ACA. Welcome, Dr. Deepak Bode.
Yeah, thank you very much, Maharashtra State Chapter ISA and Bhosle sir for the kind introduction. So, can I request the technical fellows that if I can just check once if I can share the screen, because then I can use the pointer and it will be easier for me to present the talk. Is it okay, madam?
Dr. Deepak, please share the screen.
Yes. So, is the screen visible now?
Yes, yes, sir.
Yes.
Just scroll the slides, please.
Yeah, just 1 sec. I'll just do that. Just 1 sec. Okay, is the slides now moving? Yeah. So great. Thank you very much. So in another 8 to 10 minutes, which are allotted to me, I would like to talk on left ventricular diastolic dysfunction. It is usually a very tricky topic and very few people are interested in it, but it affects everyone. So there are various myths regarding LV diastolic dysfunction. First and foremost is diastole is passive. And second one is it is cardiologist business and we as anesthetists can't assess the LV diastolic dysfunction. Another very common myth among anesthetists is all grades of LVDD are same. They just need diuretics, nothing more. And once the cardiologist has labeled it as grade 1 diastolic dysfunction, it is always grade 1. So I will try to break this myths. So basically there are 4 phases of diastole, and diastole is actually active energy consuming process. The first phase is isovolumic relaxation time, in which the aortic wall has closed, but mitral wall is yet to open. So during this period, there is isovolumic relaxation happens. During the second phase, there is rapid filling of the left ventricle, and that is usually the most energy consuming process. And this rapid filling is known to occur by suction effect at the LV apex. It is followed by a relatively smaller contribution of LV filling, that is by diastasis, and this period is usually passive filling. The rapid filling accounts for 70 to 75% of the stroke volume, diastasis less than 5%, and the last phase is the atrial kick, where there is atrial contraction and which corresponds with the P wave on the ECG. So diastolic dysfunction is basically defined as inability to fill the LV to the adequate end diastolic volume at normal LA pressures. So it is basically a mechanical dysfunction of the LV. So there are actually 2 very important components of diastolic dysfunction. One is impaired relaxation, which starts from right from grade 1 and it continues up to grade 3. But the second component is reduced compliance. The reduced compliance is usually associated with elevated left ventricular end diastolic pressures or higher LA pressures. And this particular category represents the higher grade of left ventricular diastolic dysfunction. And we are very much concerned about these patients who have got reduced compliance. So diastolic dysfunction, it may be absent at rest, but it may be unmasked by various maneuvers like exercise or sympathetic stimulation, or it can manifest because of various perioperative events like tachycardia or a simple pneumoperitoneum or bleeding or arrhythmia. So all this can unmask the diastolic dysfunction. Whenever there are symptoms associated with diastolic dysfunction, it is labeled as diastolic heart failure. So diastolic heart failure is usually a clinical syndrome and diastolic dysfunction is a mechanical dysfunction. So which are the factors predisposing for LVDD? So age is the most common cause or a predisposing factor. 15% of the patients in 40s will have some or other degree of diastolic dysfunction compared to 70% patient in their 70s. Usually, females are known to have higher incidence of diastolic dysfunction. Patients who are hypertensive, who are diabetic, patients having coronary artery disease or structural heart diseases like aortic stenosis or cardiomyopathy, those patients are very much predisposed. And another very, very important cause of diastolic dysfunction is obesity. So if you can imagine your routine OT list, so most of your patients will have some or other predisposing factors. So another important thing that we need to understand is which all factors worsen or affect LVDD in perioperative period. That is hypovolemia because of fluid shifts, pain, which is almost universal if not taken care of, blood loss because of surgical thing, anemia which is pre-existing or because of blood loss, our intubation and positive pressure ventilation, it causes extrinsic pressure on the heart because of higher intrathoracic pressure. So that may worsen your diastolic dysfunction or any arrhythmias, particularly the atrial fibrillation. So there is a lot of literature, and I'm not going to go in details of all this literature. And this excellent review article in Anesthesiology in 2016 has very clearly said that diastolic dysfunction is associated with 4 times odds ratio of landing in congestive heart. Congestive heart failure, 2 times higher risk of myocardial infarction, and almost more than 2 times higher risk for major adverse cardiovascular events. So how diastolic dysfunction is assessed? So all the slides which I am going to show from here on, 4 or 5, are done by me. So any anesthetist can definitely perform or do a diastolic dysfunction assessment, but this assessment should be comprehensive. And the diastolic dysfunction assessment starts with systolic function assessment. And systolic function assessment is done by ejection fraction assessment. And in this particular case, it is done by modified Simpson's method, and it is 70%. So you should know systolic function before assessing the diastolic dysfunction. So the first thing that we do is mitral inflow assessment. So this particular modality is done with a pulse wave Doppler, which is done at the tip of mitral valve leaflets. And you have got 2 distinct components, that is early filling, which we have discussed. Then there is period of diastasis, and then there is atrial kick. The atrial kick usually corresponds with a P wave here. So E wave velocity is measured. Then you measure the deceleration time, and you measure the A wave, that is atrial kick. So this is done by pulse wave Doppler. So the next one comes as the tissue Doppler imaging. So tissue Doppler imaging is readily available in most of the modern machines, and you need to do it at the mitral annulus, and it is done at the 2 levels. That is, one is at the septal and the other one is at the lateral. So you basically do a septal and lateral E by E prime ratios, and their average is taken. The third very important component of LVDD assessment is tricuspid regurgitation velocity. So tricuspid regurgitation velocity is done with a continuous wave Doppler at the tricuspid leaflets, and you need to measure the velocity at below the baseline. And with this help, you can measure the PA pressures. So 4 into TR velocity gives you idea about the PA pressures. And the last and very important component is the LA volume. So LA volume again is done in apical 4-chamber view and with the help of Simpson's method. And you need to index the LA volume to get an important information. So how do you assess with the current guidelines, which are published in 2016 by American Society of Echocardiography? As I showed you, all the 4 components, the E by E prime average value, if it is more than 14, your E prime septal value less than 7, the TR velocity more than 2.8 meter, and LA volume index more than 34. So all these 4 parameters are taken into consideration. If less than 50% are positive, you have got a normal diastolic function, nothing to worry. If more than 50%, then you have got some or other degree of diastolic dysfunction. And if out of 4, 2 are positive, then you cannot determine the diastolic dysfunction grade. The real problem starts when you have some or other degree of diastolic dysfunction and how you should grade it. So this is very busy slide, very difficult. Even those who are very routinely doing it don't do this meticulously, but you should do it as meticulously as this one, because then only you are labeling or grading of diastolic dysfunction makes sense. Just to give an idea, the red flag, which I'll tell you, is you just measure the E by A ratio, and if it is more than 2, then you have got grade 3 diastolic dysfunction, and that is definitely associated with high LA pressures. So if you have got a E by A ratio of 0.8, probably you are dealing with a normal LA pressures, and if patient is asymptomatic, then you need to go ahead. Then again, the similar criteria. So you need to, if you are doing echocardiography on a routine basis, you need to just print this chart and keep with you all the time so that you get the information. But the crux of this information is the LA pressure is elevated in grade 2 or grade 3 diastolic dysfunction. That's where we are very, very concerned about this patient. As you can see here, the relaxation is impaired right from grade 1 to grade 3, but the LA pressures are elevated only in grade 2 and grade 3 diastolic dysfunction. So here there is impaired relaxation in both the groups with normal or a high LAP, but here it is the reduced compliance. It is the reduced compliance, and that is the advanced grade of diastolic dysfunction. So little bit of maneuvering of the fluids and diuretics, and you can shift the patient from one grade to other. So you can actually increase or decrease left atrial pressure perioperatively if you really understand in which phase the patient is. So why there is so much of importance of grading the diastolic dysfunction? So if you have got a normal LV function or an early that is grade 1 diastolic dysfunction, so this dysfunction is very much preload tolerant. So what you really need to do is give adequate time for the LV to fill. So said that, you need to avoid tachycardia. You can give little bit of fluid to this patient to reduce the tachycardia. It is very important to maintain the sinus rhythm, and you need to increase the LA pressure by increasing the preload. So impaired relaxation patients are little easy to manage, that is grade 1 diastolic dysfunction patient. But the troublesome patients are reduced compliance, that is grade 2 or grade 3 patient. So these patients are preload intolerant. If you push a fluid point to this patient, they will land up in congestive heart failure, and you should not be giving bradycardia to this patient. It's very important to know that you should not be giving bradycardia. You should avoid all the maneuvers which increase the LA pressure, and in this particular category of the patient, you will start diuretic therapy early. In case of any hemodynamic disturbances, you would like to start with inotropes or vasoactive therapy as early as possible, and the drug of choice usually is the noradrenaline, because it will not cause much of tachycardia and it will avoid the increase in LA pressure. So here we move to various hospitals, our group practice, and this is our usual typical report, and most of you also will agree that if you see any patient undergoing surgery, you will see this kind of thing: normal, and suddenly they will grade it grade 1 diastolic dysfunction, but nothing is given in detail. So as an anesthetist, it is very important for you to know all the numbers, why this patient has particularly been given grade 1 diastolic dysfunction. If you are a little bit fortunate, you will get some numbers, you will get the diameters, you will get to know about the LA, how big the LA is. But again, the same thing, you will not get the details about the all the 4 parameters. So the 4 parameters, that is mitral inflow, tissue Doppler, TR velocity, and LA volume. So they all are very, very important for you to know that exactly this is the grade of diastolic dysfunction. So if you are lucky, like Dr. Vijay Shetty sir, Fortis Hospital, you will get a very detailed echo report in which everything is mentioned. So you will exactly know where how the patient is going to behave in the perioperative period. So all these numbers are very important, and you should always try to communicate with your cardiologist, and if they are not willing, you should start doing all the numbers by yourself. So a while back, we published this report on monitoring diastolic dysfunction with a simplified algorithm. So you will all agree that the previous algorithm which I showed is very tedious to perform in busy perioperative period. So this is a simple algorithm in which only 2 parameters are considered: E prime velocity and E by E prime. And you get grades from normal to restrictive grade. So we use this particular parameters, and we measured we assessed the diastolic dysfunction at various stages of a CABG surgery, off-pump CABG, at the baseline, at the various grafting, proximal anastomosis, and protamine external closure. And you will definitely appreciate that there are a lot of variations happening, and there is no patient with normal diastolic function in certain stages of the surgery. So just to show how dynamic this function is, sorry, this video is not moving, but you will appreciate that how dynamic the diastolic function can be. And this is another paper from JCVA, in which they assess the diastolic dysfunction in patients who were undergoing a bariatric surgery. So this one was at the baseline, the good E prime values. So the moment there is insufflation or pneumoperitoneum created, the E prime values from 13 straight away reduces to 5. And when the surgeon asks for an extensive head-low position, this value still reduces. So there is definite diastolic dysfunction which happens during various maneuvering of one particular patient. And when there is desufflation, the E prime velocity comes to normal. So what I mean is the diastolic dysfunction is very dynamic. During various phases of the surgery, this can change. Okay, so this algorithm, which I discussed a while ago, is very complex. It is time consuming. It has got multiple parameters. You need to do so many things. And importantly, these guidelines have very clearly said that these are not focused for surgical patients, because surgical patients will have a lot of dynamic changes, fluid shifts, and so many other things happening. So they are not focused for surgical patient. They are done in a patient who is stable in echocardiography lab. So there is an unmet need for a single parameter which can give you idea about the how the LV filling pressures or LA pressures are there. And there is very new parameter which is coming up, which is called as left atrial strain. And this parameter is definitely going to come in the new guidelines. And this will be like HbA1c of diastolic dysfunction. So if you see this diagram, so various parameters for assessment of diastolic dysfunction, they have got onset at variable time. So LA volume will increase lately. The E by A parameter has got a bimodal description, but there is only one parameter, that is left atrial strain, which reduces in a linear fashion. As the diastolic dysfunction grade worsens, the LA strain reduces in a linear fashion. So we did this study of left atrial strain as a single parameter in patients who are undergoing off-pump CABG. And out of the 65 odd patients that we included in this study, all assessment was done by anesthetists. And almost you will be surprised to know that 50% of the patients who are undergoing off-pump CABG had got normal diastolic dysfunction parameter. That was because it was very comprehensively tested, and probably all of those patients, cardiologists had labeled it as grade 1 or grade 2 diastolic dysfunction. Okay, so so various parameters of this left atrial strain, I'm not going to go in all the details, but they reduce in a very linear fashion, and they all are statistically significant. So I think most of the myths which I had told in the beginning are now busted, that comprehensive LVDD assessment is usually not done. So it is cardiologists usually don't do it. If you are lucky enough, you may get it, but you should start doing it by yourself, particularly in the patients who are at high risk, say a hypertensive diabetic old patient or somebody who is undergoing a major surgery. So probably you should start doing it by yourself. And the LVDD assessment is dynamic. It may not be the same in patients who is done in echo lab 15 days ago when he was very stable, and now you are dealing with a post-operative patient who is wincing in pain and who has lost a liter of blood. So it is not going to be the same. So there are variety of factors which influence it during various stages of the surgery. So same patient, as I showed you, will have different degree of diastolic dysfunction based on which stage of surgery he is. So you can't simply label one grade of LVDD to one particular patient. So you should have a sound pathophysiological understanding and judicious use of medication. Fluids are very important medication which can have a very important and significant role in diastolic dysfunction to give to administer a safe anesthetic and to have good outcomes. Thank you very much.
Thank you very much. Yeah, thank you, Dr. Borde. It was an excellent presentation, and thank you for great insights on diastolic dysfunction and various figures and various images you showed that were self-explanatory.
It was more informative and knowledgeable than debate.
Thank you.
Yeah, but then Dr. Samrat is ready. It's his presentation. And Avinash sir, will you please introduce Dr. Samrat? Yeah.
I'm happy to introduce Dr. Samrat Madnaik. Varsha, please show the slide. Sir is MBBS, MD, and DM cardiac anesthesiologist. He is fellow of Indian College and College of Cardiology, and done fellowship in ECMO and fellowship in echocardiography. He is assistant professor and consultant cardiac anesthesiologist at Krishna Institute of Medical Sciences, Dim University at Karad. He was awarded as a Best Academic Achievement Award in, hello, Varsha, it is not that slide.
Dr. Samrat Madnaik slide, Varsha.
He got Best Academic Achievement Award in 2018 and Gold Medalist in Health Research Exam conducted by Indian Council of Medical Research and National Institute of Epidemiology in 2018. His areas of interest are transesophageal and transthoracic echocardiography, ECMO, heart transplantation, and in health research. He delivered lectures as a faculty at national, state, and regional CMEs, conferences, and workshops. He is part of the cardiac team who performed the first successful adult heart transplantation in KLE Hospital, Belgaum. He felicitated by KLE University for the same. He is PG guide to the student in the anesthesiology and cardiac perfusion technology. He reviewed in the Indian Journal of Anesthesia and he had 9 publications in his credit. Welcome, Dr. Samrat.
Thank you, sir. That was really flattering. Thank you. Ma'am, with your permission, can I share my screen?
Yeah, please go ahead.
I hope my screen is visible right now.
Yes. Just scroll it.
Just a second, sir. Yeah. So, good evening, all the dignitaries, respected seniors, my colleagues, and dear friends. Firstly, I'd like to thank Maharashtra State Chapter, ISA, for arranging all these academic sessions. It's a boon for all of us to attend these sessions arranged by the dynamic team of Maharashtra State Chapter, ISA. Myself, Dr. Samrat Madnaik, I'm working as an assistant professor and consultant cardiac anesthesiologist. Greetings from KIMS DU and ISA Karad. My talk for today is grade 1 diastolic dysfunction overdiagnosed? And I am going to talk on the cons. After a very informative and elaborate lecture by our respected previous speaker, Dr. Deepak sir, he has actually made my work very simple. Following are the objectives of my talk. So, to begin with, it's summertime right now. Vacations are around. Let us presume we have decided for a holiday trip to Paris, France. Our route would be as shown in this video. Let us assume we have booked tickets of the flight and are prepared for the wonderful journey. Before we begin our journey, let me update you about a rule in aviation industry, the 1 in 60 rule. What does the 1 in 60 rule say? It states that for every 1 degree a plane veers off its course, it misses its target destination by 1 mile for every 60 miles you fly. This means that the further you travel, the further you are from your destination. Now presume that we decide to board the flight and have a very handsome dynamic captain aboard. But he has one very small lacuna, that he is a bit lazy. Now our journey has started and we are en route. There's a slight error, very small error of 1 degree on the flight path, which our captain decides to ignore because of his lazy nature. Due to the 1 in 60 rule, we slightly go off course, and guess where do we land? It's none other than Ukraine. Now, my dear friends, none of us would like to land up in that part of the world currently. And how did we land there? By ignoring a very small error. What I mean to say is it only takes a small change to make a big difference. Same applies true to all of us anesthesiologists. If we ignore small things, the impact can be disastrous. Most physicians pay attention to the LV ejection fraction, that is systole. Diastolic function is often overlooked in cardiac risk evaluation, especially grade 1 diastolic dysfunction. I would like to call Tom as the systole, the big brother, and Jerry, who appears to be small, as the diastole or the small brother, but it can be very notorious if gone haywire. Diastolic dysfunction does not cause significant problems in daily lives of patients who do not suffer from exercise intolerance, dyspnea, or pulmonary edema. However, when they reach the ward after an operation, they often end up in the ICU with unstable vital signs. Hemodynamic instability develops due to surgery-induced adrenergic stimulation and anesthesia-induced sympathetic attenuation, resulting in a lengthy stay in ICU and even death. In AHA-ACC guidelines, diastolic dysfunction is still underestimated in the preoperative risk assessment, and very few clinical data supporting its importance is available. Looking at the grade 1 diastolic dysfunction is like looking at the tip of the iceberg. If allowed to go haywire, it can be very dangerous. Patients with diastolic dysfunction need more appropriate anesthetic management to prevent postoperative complications and to aid in recovery from anesthesia. It is important that anesthesiologists are familiar with the pathophysiology, management, and surgical outcomes and are able to notice their phenotypic characteristics and diagnostic parameters. Predictions have always played a major role even in the past. In the past, the Socrates used to predict the future. Fans of Marvel movies can remember this scene where Doctor Strange is trying to predict the future and sees the outcome in a million ways. Even our Captain Cool used to predict the pitch before starting. The exit polls predict outcomes flawlessly these days. Can we do the same with diastolic dysfunction? Well, the answer to the question is yes. Age greater than 70, female sex, diabetes, chronic kidney diseases, recent weight gain, systolic hypertension, increased JVP, cardiomegaly, history of coronary artery disease, left atrial enlargement, LVH, BNP levels of more than 120, exercise intolerance, and ankle edema are all the preoperative risk factors which, when clubbed, even with grade 1 diastolic dysfunction, can be catastrophic. Now, why is it so important to evaluate? If we can tell who has significant risk factors, we can answer two questions. Who can land up in perioperative complications, and who needs a tune-up and who doesn't? If I tell you that this is an old car with a very small problem in the engine and it can run smoothly on the roads, would you like to take this car on a road trip? The answer will be probably yes. But now, if you decide to go uphill and land up in such a situation, then definitely your answer will be no. What is overdiagnosis? Overdiagnosis occurs when a disease is diagnosed correctly, but the diagnosis is irrelevant. The catch is the diagnosis is irrelevant. Dr. Deepak sir has beautifully explained how to diagnose diastolic dysfunction, and I would not go into the details of it for the dearth of time. Diastolic dysfunction is assessed with echocardiography with the help of transmitral flow velocities with pulse wave Doppler. It can be also assessed with the help of pulmonary venous pulse wave Doppler. Tissue Doppler imaging can also be used to assess the diastolic dysfunction. Tissue Doppler imaging gives us the E prime values across the septal and the lateral mitral leaflets, which gives us very vital and prime information. Recently, spectral tracking is an emerging modality. Last but not least, LA strain is another emerging modality. In near future, it is going to be the diagnostic modality for grading diastolic dysfunction, especially for the anesthesiologist in the operating room. But it needs some expertise to delineate the LA borders efficiently. We have already seen this flowchart in the previous talk, so I'm not going to explain about it or talk about it. In the medieval times, there was something called as 10 commandments, laws made to live an ideal life. Well, I would also like to tell you about what I call the 10 commandments in the OT. Let's see what they are, one each at a time. First is transthoracic echo versus transesophageal echo. Assessment of diastolic function based on Doppler findings acquired with transthoracic echocardiography may not be entirely applicable to the transesophageal echocardiography techniques. In operating rooms, we usually measure diastolic dysfunction with the help of transesophageal echocardiography. The invasive nature of transesophageal echocardiography and variable intraoperative hemodynamic state has precluded similar efforts to establish definitive guidelines during the intraoperative state. Second is position, lateral versus supine. The majority of echocardiographic studies of the assessment of diastolic function have been conducted in outpatient OPD clinics in patients breathing spontaneously in lateral decubitus position. However, filling variables of LA and LV significantly change with alterations in posture from supine to upright and left to right lateral decubitus. The third commandment is hypoxia. It is proven beyond doubt that hypoxia worsens the diastolic function. Fourth is anemia. There is a positive correlation between anemia and diastolic dysfunction. Anemia worsens diastolic dysfunction and can precipitate diastolic heart failure. Fifth is the volume status of the patient. Hypo or hypervolemia alter the loading conditions of the LV and affect the diastolic function of the heart. The patient with no diastolic dysfunction or grade 1 diastolic dysfunction can tolerate fluid boluses in a case of hypotension, as his LV is compliant. But a patient with grade 2 and grade 3 diastolic dysfunction requires restricted use of fluids and judicious use of diuretics. Sixth is electrolytes. Electrolyte balance, especially sodium and potassium, alters diastolic function of the heart. Perioperative state is always a state of high risk for myocardial ischemia. Myocardial ischemia slows ventricular relaxation and can impair ventricular distentability and worsen diastolic dysfunction. 8 is the heart rate and arrhythmias. Tachycardia and arrhythmias worsen diastolic function and can cause diastolic heart failure. Goal in normal and grade 1 diastolic dysfunction patients is to have slower heart rate, while goal in grade 2 and grade 3 diastolic dysfunction is to prevent bradycardia. 9th is the temperature. Mild hypothermia impairs left ventricular diastolic but not systolic function. Similarly, postoperative sympathetic stimulation and postoperative hypertensive crisis can cause diastolic dysfunction to worsen. Now, the 10th and the final commandment. Intraoperative state is a dynamic state with physiological and hemodynamic conditions changing minute to minute, be it because of the ventricular interdependence or because of the positive pressure ventilation. An isolated measurement should be considered only a snapshot of a continuous process. Even minor alterations in the Doppler measurement can lead to patient being classified into a different grade stage of dysfunction. Now, first look at this picture. The picture probably will get the Photo of the Year award. It's like an anesthesiologist looking for grade 1 diastolic dysfunction preoperatively when physician and cardiologist have said nothing to worry about. What would you like to say now? The gist of the image is that to let you know that intraoperatively conditions are very different and can turn adverse anytime. After looking at the so-called 10 commandments, do you still feel the diagnosis is irrelevant? Where do we stand currently? Here's a paper from Greek researchers, Diastolic Dysfunction from a point of view of anesthesiologists in cardiac surgery. They concluded when diastolic dysfunction diagnosis is made, perioperative attention to this group of patients becomes mandatory. Another paper from Korean researchers looking at the diastolic dysfunction from the anesthesiologist's perspective. They say there is no need to classify diastolic dysfunction, but to manage these conditions intraoperatively is a challenge and should be done very carefully. Robina Matyal and colleagues have written a beautiful article on the perioperative assessment of diastolic dysfunction. They concluded varying environment of the operating room mandates modification of a diagnostic algorithms which are used for diagnosing diastolic dysfunction. Why look far away when we have some wonderful work done by our previous speaker, Dr. Deepak sir? In this beautiful study, he has concluded that there are changes in grades of diastolic dysfunction in cardiac surgery. Some changes persist even post-protamine reversal. He has used simplified modified algorithm to stage diastolic dysfunction as proposed by Swaminathan et al. In the intraoperative period. It's a landmark paper indeed. He further concludes that in the paper that further knowledge of particular stage of diastolic dysfunction has clinical implications with the potential to modify therapy. Example, in patients with grade 1 diastolic dysfunction, the treatment is to increase the preload and decrease the heart rate when your LA pressures are normal. But in patients with grade 2 and grade 3 diastolic dysfunction, the treatment is careful perioperative fluid management, that is restricted fluid management, and judicious use of diuretics and inotropes to maintain afterload and prevent bradycardia. Now, let me give you one of my clinical experiences. I had a case a couple of years back, a 48 years old lady posted for CABG, very poor target vessels. She had normal ejection fraction with grade 1 diastolic dysfunction diagnosed preoperatively. The surgery lasted really long. It was almost for about 13 hours because we had to regraft her intraoperatively. And then at the end of the surgery, she had myocardial edema. Grade 1 diastolic dysfunction had converted from grade 1 to grade 3 intraoperatively. We had to keep her chest open with blood bag for 24 hours. And later, after 24 hours, the sternum was closed. Luckily, during this phase, levosimendan came to my rescue. We were able to successfully discharge her after 15 days. She regularly comes for follow-up now. She even still has now grade 2 diastolic dysfunction and is on Arrhythmias. What I'd like to tell you is it is important not to overlook patients with asymptomatic LV diastolic dysfunction, even if it is grade 1 diastolic dysfunction in the preoperative evaluations. Modified strategy based on the TE-derived standards should be used because there is not yet an evidence-based treatment yet. Timely simple measures like avoiding hypothermia, anemia, maintaining preload and afterload, judicious use of diuretics, avoiding hypoxia, correcting metabolic abnormalities, maintaining sinus rhythm and heart rate can help prevent the worsening of diastolic dysfunction to diastolic heart failure. Newer techniques like LA strain, speckle tracking, and velocity vector imaging may allow us to better define the LV filling dynamics and are more accurately and help us accurately classify the diastolic dysfunction. In this new medical legal era, it is better to be vigilant. Overdiagnosis does not always mean overtreatment. It is always better to be vigilant. Vigilance means the action or state of keeping careful watch for possible danger or difficulties. In fact, the motto of ISA itself is eternal vigilance. Then how can we be so invigilant about grade 1 diastolic dysfunction? Knowledge coupled with vigilance can sail you through difficult times. Always keep cool even in bad situations. What I believe is treat the patient and not the reports and keep cool even in bad situations. Few of the references that I have. Thank you.
Thank you, Dr. Samrat, it was an excellent presentation, and the slides were also very interesting. That's now
It was like a lecture from both the speakers. Rather than a debate, it was like a lecture.
Yeah.
Both had made very beautiful slides, but the audience is in confusion at the moment because we are still not aware whether it is overdiagnosed or not. So Dr. Deepak Borde would like to listen from you whether it is overdiagnosed or not. You have to say in the favor of prone.
Yeah. So
for next 2 minutes.
Yeah, thank you very much, and must congratulate Dr. Samrat for this excellent presentation, and I must thank him also for including our study in his presentation. So basically, it was not a very clashy pro-con debate. So both of us are almost on similar page, but trying to say it from two different angles actually. So my personal advice, like to all who are interested in point of care ultrasound, is you just pick up the probe and start doing echocardiography by yourself. So you will learn so many new things when you do it, whether it is a simple appendix or whether it is an CABG or whether it is a neurosurgery. If you have got the probe available and machine with you, you are one of the lucky fellows. Please pick up the probe and start doing echocardiography by yourself. First, you will struggle. You will just not see anything. You will just see a satellite picture. But slowly, it's not a very difficult thing. If I can do it, everyone can do it. Okay, and most of the times it is the technicians who are doing it. So we are definitely better than technicians, and the moment you start doing it by yourself, you will slowly start knowing the intricacies. And believe me, it like many a times, just because of there is an preoperative echocardiography report from a cardiologist, but we have actually altered, or we have completely changed which surgery is to be done, and the cardiac surgeons now are really happy, and Dr. Samrat will also agree with me that they believe more in our echocardiography rather than that done by a casual approach by a echo technician. So it is very important always to put it in terms of clinical perspective. So that is very, very important. So you should first take proper history of the patient and then only do an echocardiography or read echocardiography report. So that is very, very important. And any red flag, you should immediately share with your surgical colleague. That is just not to postpone the case, but everybody should understand that there is something important that you have picked up based on your own echocardiography report. So always reveal your diagnosis. Oh, this is really difficult diastolic dysfunction patient, so we are going to struggle with this patient. So surgeon also will try to do surgery as fast as possible. He will try to reduce blood loss as far as possible. That is wishful thinking, but still, so at least you can alert the entire team based on what your finding is. So I think that is the most important thing that you can do, and that will definitely 101% change the way you practice anesthesia. I can guarantee that. Thank you very much.
Thank you, Dr. Deepak. Dr. Samrat, what do you have to say on this?
Yes, ma'am. I think Dr. Deepak sir and me, as he said earlier, we are almost on the same page together, just trying to convey the message from different viewpoints. What I believe is diastolic dysfunction has to be given utmost importance. It is not that diastolic dysfunction is overdiagnosed. Even grade 1 diastolic dysfunction, if unattended, especially in long surgeries, and the dynamic nature of the intraoperative state, like the changing temperature, the changing the blood loss, and considering all the other factors, I feel that even grade 1 diastolic dysfunction can worsen. Unfortunately, there are no validated studies currently in literature which prove this point. But that doesn't mean we should be not vigilant about the grade 1 diastolic dysfunction. It has to be taken seriously, especially in this new medical legal era when we have to face the patients and their relatives. It's always better to document this and explain them the possible complications and the risks, what can occur or what can go wrong. As I've already told you, personally, I have seen a few patients turning bad intraoperatively. We did not know what things went wrong. But fortunately, in cardiac surgery, we use a transvascular echocardiography probe. That is why we were able to diagnose a few things. Also, I'd like to add one more thing, that currently the diagnostic guidelines which are given by the American Heart Association or American Society of Echocardiography are the 2016 guidelines. LA strain imaging is coming in a big way. I think even Dr. Deepak sir will agree with me. In coming future, it is going to be the modality for intraoperative diagnosis or monitoring of this diastolic dysfunction or classification of this diastolic dysfunction. Because what we are more interested is the increased patients who can have increased LVDP or increased LA pressures, and treatment algorithms for these patients change accordingly. So I believe that diastolic dysfunction has to be taken seriously, and we have to properly cater to it in the preoperative as well as the intraoperative period.
Thank you so much.
Great.
We would like to hear from our moderator, Dr. Vijay Shetty, sir, his view on this diastolic dysfunction, grade 1 diastolic, especially grade 1 diastolic dysfunction. Vijay, sir, please.
Vijay sir.
Okay. Thank you, Samrat and Deepak, because this was an excellent presentation. I think it was worthy of being presented in a cardiac anesthesia meeting actually. So I'm sure that a lot of stuff has gone over the head of many of us. I wouldn't blame them because there are a lot of numbers, and I like Deepak correctly said, it is not every day that we get to monitor diastolic dysfunction. And looking at it, see, when you're having a cardiac patient in the OT and you're doing a CABG, a lot of things, and both these guys are experts, and they're fed up of systolic dysfunction, so they are looking at diastolic function as well. But I can be very honestly and tell you that most anesthetists won't, even cardiac anesthetists won't look at diastolic dysfunction if a cardiac surgery was going on, unless they have landed up into problems. So that having been said, we are talking about people who don't have facility for even a transthoracic transvastular echo. So few of the points that I would reiterate is that there is an entity called diastolic dysfunction which we need to be aware of. Number one, anybody with a normal systolic function, which is our bread and butter, can still have significant amounts of diastolic dysfunction. But whether grade 1 diastolic dysfunction has to be given the importance, given the way that it is, routinely diagnosed as one. For example, anybody with above 60, 65 years is bound to have diastolic dysfunction. It is given. Anybody with a LVH will have. Anybody with hypertension will have. Like Deepak correctly mentioned, about 80% of a patient will have grade 1 diastolic dysfunction per se as a diagnosis, and it is correct. But my problem is whether that grade 1 is grade 1 or it is actually worse is what we're not very clear or sure about. So I don't think that if a cardiologist has done a grade 1 diastolic dysfunction, I have anything to do to tell it is grade 2 or whether it will worsen. But most important thing that Samrat rightly mentioned, this patient has to be watched because you have normal EF patients landing up in problems in the post-operative period, very not uncommon. Sometimes re-intubate them. Sometimes they go into cardiac dysfunctions and edemas. These are the very patients that we know as preserved ejection fraction failures, and these are one of the problems in them is that the diastolic dysfunction was the one which is. So I would reiterate that we need to work ourselves to understand this problem. Number one, and there are certain goals that are given in the books also. It's easier said than done. Like Deepak said, if there is a relaxation problem and if there's a compliance problems, our therapies are different. Now, who's going to tell me that which kind of problem is what? And so in one, I could give fluids. So what we have to be is that one, we need to have adequate monitoring. That means certainly if it's a long patient, like long surgery, like Samrat mentioned, I would definitely put in an arterial line because monitoring the pulse pressure is a very important criteria for these patients. And if your pulse pressure can be kept below the diastolic pressure, that is one of the ways that you see that you're on the right goal. If you find that your pulse pressure keeps on increasing, because more pulse pressure means there is more stress on the heart, which is something that again we were never taught in clearly in our anesthesia practice. So you monitor the pulse pressure. That's the difference between systolic and diastolic, and that is one thing because we always focus on the either systolic, sometimes the diastolic, and often on the mean. But the pulse pressure becomes a very important monitor when you monitor diastolic pressure. So from tomorrow onwards, if you're doing an elderly person with the borderline heart function, with somebody with a systolic dysfunction, of course they'll have diastolic dysfunction. But somebody with even with the normal EF also, they need to be monitored for this pulse pressure, how the pulse pressure changes. And you'll find that in somebody in whom you managed to keep the pulse pressure below the diastolic pressure, usually they will not have any problems. But you find that your pulse is running away, then your game is getting more and more difficult. The other important thing is that the drugs that Samrat and Deepak mentioned about milrinone and levosimendan, we need to build practice, because as cardiac anesthetists we use it very often, very commonly. But in non-cardiac practice, these drugs usually we don't go beyond NORAD and adrenaline in our normal practice. So we need to work very closely with our cardiac colleagues to understand how do they titrate, how do they produce, how do they prepare, and what are the events. Like for example, if you just start a milrinone just like that, you will end up with severe volume depleted status and hypotension. Then there will be another problem to take care of. So we need to work very carefully with them to understand what are the pros and cons. So I think somewhere down the line, madam, you can arrange a series about you, including these two good speakers only about the newer drugs in cardiac anesthesia, which would mean a lot for the non-cardiac anesthetists as well. So excellent presentations. Double thumbs up for both of you, Samrat and Deepak. Excellent slides and a lot of good information. It was good relearning for me as well. Thank you so much.
Thank you, sir.
Thank you. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you so much. I think Dr. Uday Gandhi is not available at the moment. He's still busy in OT, but he will be joining our question answer session.
Sir, Uday sir, are you available?
He is logged in, but he is not able to speak at the moment because he is in the OT. So he said he will be
question
joining.
answer, I will come afterwards. What is question answer? I will join afterwards.
Okay.
Okay.
Let us take some questions from the chat box. Dr. Anita and Dr. Avinash, please.
There is one question.
Actually, there are not many questions. There are many comments and very few questions, but actually difficult to understand the question. One question is, in ENT case, intraoperatively there is a hypertension, and preoperatively there was a borderline hypertensive patient. That means probably a controlled hypertensive, preoperatively okay, mild hypertension, and intraoperatively there is a severe hypertension. So is it okay to manage with NTG and beta lock? That is the question. Dr. Samrat, would you like to take that?
Ma'am, can you just repeat again, ma'am? I just missed what you said.
Very confusing question, actually. The question is, the patient has it's the ENT case and patient has a hypertension intraoperatively, and preoperatively it was okay. It was a mild hypertension.
It is borderline.
Intraoperatively, yes. Intraoperatively is hypertension. So is it okay if you use NTG and beta lock, or you would like to use any other drugs? That is the question.
First of all, ma'am, what I'd like to know is what is the cause of that intraoperative hypertension that has led to this situation. Whether it is the reduced depth of anesthesia, whether the patient is in light plane of anesthesia, whether the ENT surgeon has administered or infiltrated drugs like adrenaline, it all has to be seen.
Yes,
also,
like to rule out all these
all the causes.
Yes.
What I'd like to do is I'd like to deepen the plane of anesthesia, check all the parameters, see whether the patient is hypoxic. I mean, routinely, what all the things we check, I'd like to do that. Correct any metabolic causes. But if it is an acute emergency, yes, I'd like to go ahead. If it is not responding to the increased plane of anesthesia, I'd like to go ahead with first with beta blocker, followed by NTG. And NTG dip can be definitely started if required, which can be later.
What is the choice of your beta blocker, Dr. Samrat?
I'd like to go with if it is associated with increased heart rate also, that is tachycardia along with hypertension. I'd like to go with IV metoprolol in incremental doses.
IV metoprolol, okay. And in association with NTG, or only metoprolol first and then NTG?
Can be started, ma'am. Can be given in association with NTG if it is an acute emergency. And otherwise, it can be done in a graded approach also. First, you can give a shot of beta blockers, see how the patient is responding. And if not, then you can start the NTG. But both can be started together also.
Yes.
But
So
beware, while administering these drugs, there can be precipitous hypotension, which can occur.
But with NTG, we can control the BP very well than beta blocker.
Sir, NTG is specifically a venodilator. It will just cause venodilatation. It will reduce the preload on the heart. Beta blocker will reduce the cardiac contractility and also decrease the heart rate. So that's what I'm saying. What the cause is, it depends on that.
Titrate, we can titrate very well with NTG.
So the
Yes,
take-home
yes.
message is actually in such cases in ENT and when the patient has a controlled blood pressure pre-operatively, most probably it is some of the other causes like light anesthesia or the adrenaline infiltration by the surgeon. So, but in as Dr. Samrat said, we can use NTG and a dose of beta blocker if we need.
And a good friend dexmedetomidine.
Yeah,
Yes.
Correct.
Most of the time we use propofol. Is that correct or
Yes,
most of the anesthesiologists use propofol as a drip.
See, it will deepen the plane of anesthesia, so it serves one of your purpose.
Blood pressure also.
It will deepen the plane of anesthesia. So if
But
that
shouldn't
is
be used as an antihypertensive actually.
It should not be used.
Yes. Yes, that was what I want to know. Yes.
Vijay, would you like to put a highlight? Would you highlight on this? Would you like to put some expert comments on this question, Dr. Vijay?
Madam, I think if you ask in my humble opinion, like Samrat said, unless there is something going wrong, your patient's blood pressure will never shoot up. If it will never shoot up unless there is a vaporizer leak. But that is what we are trained for, like keeping everything. If your patient who is asleep is going to have a hypertensive response, that will never happen unless there is a problem. The only thing that remains is what Samrat said. The second thing is undiagnosed pheochromocytoma, thyrotoxicosis, all those things, or a myasthenic crisis. These are the things rare things which can be there, which is hidden and come to the fore. Otherwise, 99.99% of the times it is something that we are erring in. So you can definitely deepen the anesthesia, then look for the cause and then treat it. It will never ever happen that you have an intraoperative hypertension in a otherwise okay patient, even if the patient was a hypertensive. What I'm saying is sudden hypertension, everything was going on and suddenly the BP goes up. That never happens unless there is an error. Of course, doing intubation and all those things are different. We already know the cause. But whatever therapy Samrat mentioned and you've said across, definitely yes. But please don't use dexmedetomidine to control a hypertension. That is never done. Sometimes you might end up with even more hypertension. Please don't use dexmed for everything.
Yes.
If you are having a problem, like Samrat said, you can use metoprolol, or even if it's something to do with the adrenal infusion, I would use probably esmolol, because quick in and quick out, and by the time it work out. Correct. But if the patient has got everything you ruled out and you think that the BP is still remaining high, then definitely we would go for something to control it. Like NTG is not an excellent drug, I would say, in today's anesthesia. I beg to differ, because it will always cause tachycardia. If a patient is not on a beta blocker in the beginning, your tachycardia is only going to make it worse. Sometimes, very rarely, even significant hypovolemia can cause severe, because of if a patient in light, patient has got some blood loss and lightened it, and even if the patient is losing blood, there can be hypertension because of the adrenergic response, and if it's a very sensitive vasculature, it can cause hypertension even then. So there are a lot of things that we need to be aware. And what I always say, that if you have such an experience, always share it, because everybody learns from the same error or mistake that you have.
Okay, thank you, sir.
Anita, may I add one thing?
Yes,
please.
I happen to do a lot of commandos, because for last 18 years I work with an onco surgeon. So I assume ENT surgery is equal to something mandibulectomy, maxillectomy. And in my experience, dexmedetomidine given even before neck dissection gives a very good plane of anesthesia, and you have to prepare before surgeon opens the mouth. You have to lower the BP even before surgeon puts the mouth gag. So that give a sedative dose of midazolam, give some 2-3 cc's of propofol, deepen the anesthesia even before surgeon opens the mouth. And one important point is you can use 10% xylocaine spray to a lesion. So that gives a very good control of blood pressure, apart from all the things like dexmedetomidine given pre-operatively only, that is after induction maybe, and propofol drip, and sometimes xylocard 4 cc of bolus and 5 cc of xylocard in 500 ml. If you give over 1 hour, most of the surgeons finish it in some 30 minutes, that maxillectomy or mandibulectomy, and that gives excellent bradycardia and good control of blood pressure.
Yes, many people use xylocard, and it. But what is your opinion? I mean, other people, would you like to comment about intravenous lignocaine?
This
Uh,
Yes,
question is to Dr. Vijay, na?
Yes, sir. Vijay, sir, are you there?
Yeah, sorry, ma'am. Intravenous lignocaine at the time of intubation, you're saying, or
No,
No, to load
such a situation, when you want to lower the blood pressure, when
and tachycardia.
yes.
Yeah. So again, I would reiterate that the treatment is usually very simple. We use as less drugs as possible, and IV lignocaine as a when you anticipate and you know that the response is coming, it is a good drug. But as such, it is also got mild depressant properties. So I would not recommend these drugs. We got enough drugs, and I totally agree that the propofol is the best drug in such an event that you have, that anesthesia is light is the most likely thing. And Manjeet madam, I was not if it came across that Dexam is a bad drug, it's not what I'm saying. I'm saying as a treatment for the hypertension, we should not use it. But each and every one of us, depending on our practice, have developed our protocols to keep the BP under control. We should stick to that and add any other drug that you would think or to do it. But in an emergency, and when you have propofol is the best drug to deepen the anesthesia. Some people have suggested a SIBO bolus and all, but I would still think that finding out the cause is the most important thing, and elaborate once again that usually it is some error on a point which has led to this, unless it's an undiagnosed systemic problem.
Okay, thank you, sir.
There is one more question.
We'll go to next question. One is in grade 3 hypertension, what will be the lower limit of blood pressure so that end organ failure will not be there? Yes, anybody?
Grade 3 hypertension, we had agreed that we will not go ahead. Number one, and the second thing is that in grade 3 hypertension, by and large, you would expect end organ damage to have occurred, and in this patient probably we'll put all the lines and just allow maybe a 20% 30% drop in the blood pressure. Obviously, in this patients are very high risk. I'm assuming this is an emergency operation, so a lot of things will not be in our control. But most of the times, I find that even in these patients, after the anesthesia is induced, usually the things settle out. A lot of tachycardia settles, the adrenergic surge goes off, and usually the patient settles off quite well. And most people have said that don't have sudden falls in the BP, don't avoid those parts. So like if you have a 180 systolic, probably I'll try and keep it on 140, 150. Another interesting thing is that in these patients, we don't have anything major to monitor the organ function. For example, urine output is very excellent. Like Dr. Uday is not that, he always taught me this part, that the urine output is the poor man's cardiac output monitoring. Everybody has that by and large in major patients. Nowadays, we also use the NIRS or the cerebral oximetry to see that their organs are well perfused. This is when there is a requirement for lowering the BP, that you are at least perfusing the organs well. There are a couple of other instruments which we can use to monitor organ function. But having a very reliable arterial line is very important, because our BP curves will not be very useful for these patients who are out of range, meaning very low BP or very high BP. Have invasive lines with a properly zero transducer, which can give you a very good BP to target and follow, and also in the post-op it will be very useful.
Okay, thank you, sir.
Thank you, Dr. Vijay. And is Dr. Sheetal there? There are
Anita, Sheetal had to leave for some emergency.
Okay, so one more question which I also would like to know is dexmedetomidine safe in cardiac pathology? So is the use of dexmedetomidine safe if the patient has a cardiac pathology? Who would like
Deepak and Samrat can answer this.
Yeah, yes.
Yeah, when
when
dexmedetomidine was started, it was very enthusiastically taken in cardiac anesthesia, and it was projected as a magic bullet. But somehow, at least in my little bit of experience, I don't use it very often in cardiac surgery, for the reason that most of our patients will be on beta blockade. So they will usually have tendency to have bradycardia, and they will, more than bradycardia, it is usually the vasodilatation which causes more of a problem. So ultimately, you end up giving a lot of volume to these patients to maintain the blood pressures, and that is not what we really want in cardiac surgical patients. So personally, I have not been using dexmedetomidine in cardiac surgeries. But yes, in non-cardiac surgeries where as an adjuvant to as a multimodal analgesia method, and as Madam Madnurkar told, to give good depth of anesthesia as an adjuvant, it is excellent.
Yes. Thank you.
Dexmed, ma'am, in cardiac surgery has been used. There are many reports in the literature and many evidences also that it can be used. But personally, if you ask my opinion, Dexmed, I personally do not advocate using Dexmed in a cardiac patient or a patient having cardiac condition. For two reasons being, first is boluses of Dexmed, what I have seen is they usually cause precipitous hypotension, which are very notorious to treat. So maybe you can start with some maintenance dose directly for these patients, but achieving plasma levels is really difficult, especially in the intraoperative period without a bolus dose. But what I have personally seen is if you give a bolus dose of Dexmed to load the patient, it causes a lot of hypotension and causes a lot of problems. Personally, I don't use Dexmed in my practice. My patients are well off with opioids and other analgesics.
Okay, so bolus dose, no, but infusion, you don't want to use it in infusion also?
Can be used, ma'am, but as I said, achieving plasma levels take a lot of time, and I think by that time your surgery will almost be over in non-cardiac case.
Okay.
And there is lot of evidence for use of dexmedetomidine in post-operative cardiac surgical patients to reduce the incidence of delirium. So it has been shown in a lot of randomized control trial. But again, it is the same story. If you have to use it, the person actually who is using, particularly if a non-anesthetist is in your ICU, they are not very much familiar with this drug, and it becomes very, very difficult. So it is a missile, but if it is a misdirected, then it will cause a lot of issues.
Yes.
Yes. Okay. Thank you.
Non-cardiac, there is no question. It is an excellent drug, but particularly in cardiac patients, so looks like both our speakers don't want to use Dexmed in a cardiac patient because it might be.
Deepak, the interest was in cardiac patient coming for non-cardiac surgery, especially hypertensives and all. My thing is that I think they're all keeping quiet, but most of them will be using it in their practice. If your ejection fraction is maintained, I think most of them will start a small dose like Samrat mentioned. And you would say in about 20% patients, 20 to 40% patients, only 1 ml would go, and then it would never be used throughout the surgery. That is what usually the story is. In some of the patients, it does well for half the surgery, like Madam really mentioned about the maxillary, the initial part of it. But please don't use it if your patient has got less than normal ejection fraction. Please don't use it if your patient has got any kind of arrhythmias. And certainly don't use it if the patient has got multiple cardiac drugs going. So these three, if you follow, and you keep a very stringent watch on the blood pressure by arterial line, you know when to stop, and then give it some half an hour, it should come up if the surgical stimulus is intense enough. I think that would be it. I would like to add that Deepak, in Mumbai, a lot of people who practice minimal access cardiac surgery are using Dexem, and they swear by it. Even I have the same experience that I don't use too much of it in my practice, but they have very good results, and they're very happy with the way it is, giving us confidence that it can be used in patients undergoing non-cardiac surgery. But please be very careful for these 3-4 contraindications or
you should have that expertise to handle that missile. Then only probably you should venture into it.
And one more question I would like to know is if there is an intraoperative hypertension, and so which is your drug of choice? You have deepened the plane of anesthesia, you have given regional anesthesia, pain relief, everything, and there is a severe intraoperative hypertension. So what is your drug of choice?
Especially for non-cardiac surgery. I think most of us are interested for non-cardiac.
Yeah.
I think beta blockers.
Which beta blockers, sir?
Metoprolol in
small.
But small problem is nowadays it is not available very freely. Somehow they have stopped manufacturing. I don't know. It is at least not available in our part. So
it is available here, but it is very short acting actually.
So to tide over the crisis period, it can be very well used.
I agree with Dr. Deepak sir, ma'am, that yes, I'd also like to go ahead with beta blockers. First choice of drug will be metoprolol, as he rightly said. Esmolol is a very ultra short acting drug. The action will last just for 5 minutes or lesser than that. The action will immediately decrease. if the intraoperative hypertension, or if you want to control the hypertension for a very brief period of time, that time I'll suggest you use esmolol in the dose of 0.5 to 1 microgram per kg, 0.5 mg per kg. You can use it in that dose. If you are planning to have that control of BP over a longer period of time, better drug would be metoprolol. Labetalol can not metoprolol infusion, IV boluses can be used, ma'am. And labetalol can be also used. It can be used in the form of an infusion. But personally, I don't have much experience with the use of labetalol because most of the times I have been well off with metoprolol, use of some venodilators like NTG, or in rare cases, sodium nitroprusside.
Labetalol is more commonly used in obstetric patient now.
Yes.
Yeah,
For
even
control of
Commonly used.
AIH and hypertension.
even for control of hypertensive intracerebral bleeds, we do use labetalol for control of blood pressure.
Right.
But
So,
about my experience for using labetalol infusion, especially to control blood pressure in patients who have hypertensive intracerebral bleed, it usually takes some time for blood pressure to go down. So I don't think I have not used in OT for intraoperative control of blood pressure, but whatever my experience in the neurointensive care is that it takes some time to get the BP down, not like metoprolol or esmolol. So whether it will be useful in OT, I really do not know. I really do not have any experience. Dr. Vijay, you want to comment on IV labetalol? We all are happy at the moment with IV esmolol and metoprolol, but what about IV labetalol in OT?
Yeah, esmolol, like if you are using esmolol, madam, my one comment is that you have to be ready to be able to use it as an infusion. Then only it will be helpful over a certain amount of time. But very correctly, like Dr. Bosle and you mentioned, it is a number one drug that is used now for obstetric practice, for AIH, and for neurosurgery practice. I personally think that if nothing is working, it is definitely a good way to go. And one of the important things about managing hypertension is it should never be sudden. So if the drug is acting slowly and you are taking other intraoperatively, if you're taking other means of other depth of anesthesia and everything else is okay, then having a slow control over that hypertension is not such a bad thing, because your patient not bleeding away or anything. You can have a good control and then you can titrate it and stabilize it. In fact, I am very scared of drugs which acutely control BP because then you are left discontinuing and then it's a big yo-yo effect. So labetalol works very well, and I think sometimes we end up giving a lot of labetalol. And then the patient remains bradycardic for some amount of time. But as long as the BP is controlled and there are no ischemic events, I think it works. It is a very good drug to have in your armamentarium, I would say. Just like metoprolol, small doses of metoprolol, 1 to 5 milligrams, 1 milligram liquids over every 5 minutes usually do the trick. But if you want it, your intensivist friend also to be happy, then we can. And you see, you are expecting it to go up. You can warn them that to have a labetalol infusion ready and just shift from the metoprolol IV boluses onto the thing. And the way the metoprolol also acts gives you an idea about how the labetalol will probably take its course as well.
And what about IV clonidine, sir? Somebody is asking. IV clonidine?
So IV clonidine, I had used IV clonidine only when we were doing spine cases in SIAN in late 90s. But I would say don't use a long-acting drug which you want to act in a short duration. You have something that is titrable, is effective. So clonidine is not the drug of choice for managing anything. So what these kind of things, if you just read something on hypertensive emergencies or hypertensive crises, you will know what drugs you are having, what drugs can be used, and you know what is available in a hospital, and then just keep them to use it. But number one is always anesthesia. Like if you're intraoperative, your anesthesia will do majority of problems to be solved with that. You need to do metoprolol and labetalol only occasionally. And see, if you are not able to control BP with the inhalational agent, with the propofol infusion, then something is really grossly wrong. So there is this real oversynthetic overstimulation happening. Then the beta blocker will be required to manage the situation, either a metoprolol or a labetalol infusion. The thing with diabetes, you start infusion and you are you can just press the buttons and control it, and you can have a decent control. Whereas a bolus thing goes in of like something like a clonidine or a huge amount of beta blocker, it is difficult to reverse the actions of what you give in a non-infusion form.
Yes. Thank you, sir. My question is, which antihypertensive drug should be stopped or withheld before surgery?
Deepak, yes.
Yes.
This is the most tricky question. And what we usually do is keep them where they are. Whatever they are taking, we just don't stop it. Whether it is ACE inhibitor, beta blockers, if not there, we just start a small dose. But whatever they are taking, we just continue with what they are taking. So we don't
But
stop.
the guidelines say that you stop
Yeah.
a morning dose of this.
ACE inhibitor. There is a lot of debate, and I think Vijay sir has given a very excellent talk last year on all this maintaining which drugs to start and which drug to hold and in which. But to keep it very simple in routine clinical practice, we keep them where they are. I think I may not be correct as far as the evidence is concerned, but that's what I've been doing.
And so second question is when the last drug should be given? If we are giving, at what time?
Last antihypertensive.
Antihypertensive.
Okay.
I mean, if they are taking HS dose, we give it as HS dose. If they are taking it as a morning dose, we give it as. I mean, wherever they. What is there any other thing? I am not aware of.
Is there any time difference?
I'm not aware of any difference in timings of giving antihypertensives.
I think he wanted to ask you that whether that antihypertensive, whichever he is taking, should be given in the morning of the surgery. That's what he's asked. That's what he wants to ask. Whether we should give that, that drug has to be given.
Mandatorily as a morning dose. No, but if the patient is on HS dose, like many of the patients who are well controlled on a single medication, they will be on HS dose. So you continue it as HS dose. There is no need to give any additional dose in the morning.
Most of the surgeon, they give the antihypertensive drug just before 1 hour before the surgery. So when we go to the operation theater, the BP
should be normal.
So
no, but there can be precipitous hypotension.
Yeah, it can be a dangerous practice.
Yeah. It can be with propofol and even spinal. Yes.
They give depin, sublingual depin.
Yeah, depin. That is the most dangerous thing that you can do. I think that should be strictly discouraged.
Okay.
Ma'am, I'd like to add some few points. First thing, what you asked about ACE inhibitors and ARBs. As per what I know in the literature, even I think in the Millers, it is a debatable topic. One line of thought says ACE inhibitors and ARBs have to be continued till the surgery. They should not be omitted. But in the same way, there is another school of thought that says you have to omit ACE inhibitors and ARBs 1 day prior to the surgery. So it's a point of debate. I think even in Miller's latest edition, that is what they have said, or that is what they have given. Second thing is, in cardiac surgery, we usually avoid ACE inhibitors and ARBs 1 day prior to the surgery, not 1 day, on the day of surgery, or at least 12 hours prior to the surgery, for the reason that there are a few reports or literature which says that if a patient is on ACE inhibitors and ARBs, the patient can have precipitous hypotension when the patient goes on cardiopulmonary bypass. So that is the concern for a cardiac anesthesiologist. That is what, as per my knowledge. Second thing, in a few patients, I have personally continued these ACE inhibitors and ARBs, and I have found absolutely no problems. Till now, in my practice, I have not found any single patient who was on ACE inhibitors or ARBs which were continued, and patient having precipitous hypotension in the intraoperative period, especially while coming off bypass or while coming off cardiopulmonary bypass. Second thing, as we were discussing, ma'am, when should the dose of drugs be given? I feel, as Deepak sir has rightly said, as the drugs are going, we need to continue in the same fashion. There is a trend, very recent, not a recent trend, but this trend, what you explained, that surgeons usually tend to give this antihypertensives earlier before taking them for surgery. Even I had a few situations like this, wherein the surgery residents especially, they even give a dose of diuretics, and as sir said, a dose of dipin, and then they get them inside the OT or operating room. What I do is I tell my residents or whoever is posted to have a look at the blood pressure values previously in the last 2 or 3 days, and then correlate accordingly. That is what I follow.
Is there any rebound hypertension after stopping these drug AC inhibitors or angiotensin receptor blockers?
Sir, if you have started them acutely, I think there are a few chances that there can be rebound hypertension. But if a patient is already on ACE inhibitors and ARBs, and you stop them for maybe a 12 hours or something like that, usually in my practice, I have not found anyone having hypertension of the sort what you are talking.
No,
Okay,
because
thank
they
you.
are very long-acting drugs. So usually with one dose, if you omit, then there is no rebound hypertension. But I have found in 2-3 patients, I had to put noradrenaline drip for non-cardiac surgery. Patient on ARBs and ACE inhibitors who had taken morning dose, and they had very precipitous hypertension and who was not responding to mephenteramine, and I had to put them on noradrenaline for at least 1 hour, 1.5 hours. So if you are accepting patients who have taken ARBs or ACE inhibitors, then you must be ready with infusion pump and you must have access to these drugs to take care of the precipitous hypotension. I think the guidelines say that you omit the morning dose. That is what guidelines say.
I agree with you, Anita. I agree with you.
Yes.
For non-cardiac surgery, at least the guidelines say that you omit ACE inhibitors
Yes.
and ARBs.
And it is only about ACE inhibitors and ARBs, but you can continue the calcium channel blockers and you can continue the other drugs, but not ACE inhibitors and the ARBs.
Yeah.
But some surgeons says morning dose of antihypertensive cause exaggerated hypotension on the day of surgery, so they omit
That is what I'm
all drugs.
saying. No, you can't omit all the drugs.
Yeah, I think
only one small comment I want to make, just as out of interest in discussion.
Please.
It's obviously safe to stop the ACE inhibitors. I'm sorry, you're lost. I think this discussion is still on the ACE inhibitors only.
Yeah.
So one of the indications for ACE inhibitors is say a patient who has heart failure or the diastolic dysfunction that we were talking about. So in these patients, if the surgery permits, then I would certainly like to give at least half dose of it, because the purpose, the patient is doing well in spite of having diastolic dysfunction, is because one of the reasons is the ACE inhibitor. So denying the patient this when at his time of most need probably needs to be talked about. So supposing you're giving a spinal anesthesia and you're going to cause precipitous fall, then definitely it would be a good idea to stop. Whereas if you're going to do a very significantly invasive surgery like a commando, etc., I would really want to give him half dose of ACE inhibitor in the morning in these kind of indicated patients where there is it was started for failure or it was started for diastolic dysfunction. That is my opinion, and some guidelines do mention that you can give half the dose of this, but obviously it's such a difficult thing because everybody practices anesthesia differently. There are a lot of different patients, so the best thing is to take a individual call, and then, like Madam Anita mentioned, you stand up to your responsibilities and be ready for dealing with either you want to give or you don't give the patient. The most dangerous patients are in whom you have started this drug just 1 or 2 days prior, and then you give a spinal epidural, and then they have these things that Madam mentioned, that you end up with this having a NORAD support. Thank you.
Thank you so much. Avinash, if there are no more questions, I think
it is neat.
Yes, Uday, yes.
Yeah, sorry. I'm very sorry. Just exactly when we don't want the case get delayed in cardiac, especially. I'm still in the OT, so all that tamasha of balloon pump that was going on. The pressure was bad anyway. So sorry for not being there. Excellent talks, I must say, especially the second 2 talks. First 2, of course, I have commented on the diastolic dysfunction, and Deepak Borde, of course, is still my last word in echocardiography. He was, and he is, and he will remain. And excellent talks, excellent discussions. I think everything is discussed well in depth, and I'm really happy. I was listening in between, not 100% of it, but excellent discussion on only few points. I think Vijay also has said a lot of things which are very correct, practically speaking. And I don't do so much, almost no non-cardiac case, I do only cardiac. But all these discussion about beta blockers, ACE inhibitors, ARBs, I think there are a lot of studies which confuse you when you go into depth of all these studies. But at the end of it, if patient is on all these drugs, antihypertensives, any group of antihypertensives, even ACE inhibitors for a long time, we need to continue it, even if it's a non-cardiac surgery. we can't just stop on the day of surgery, because the surgeons might think just to make surgery happen they can do anything, but it's not good. As an anesthetist, we must continue all these drugs. There is enough evidence in the literature to say that all these drugs should be continued. The second thing is our practice is such that I'm sure even in non-cardiac, we do a lot of cases in late afternoon, late evenings. So we must not forget to give dose of all these antihypertensives. If patient is taking suppose 2 doses, so you must give afternoon dose also. We always seen that in cardiac also, when patients they are taking third patient suppose of the day, they definitely have more hemodynamic instability, because we always say that patient be fasting from 7 a.m. and they give a morning dose and they forget to give the afternoon dose of all these drugs, cardiac drugs especially. So that one point we should always make sure that patients taken up late in the afternoon or evening also should receive their afternoon or evening doses according to the time that you are taking these drugs, the patients enrolled. I think, yeah, that's it. And diastolic dysfunction, I think what Deepak said is excellent. I mean, there's no doubt about, and very, very detailed discussion about diastolic, what diastolic dysfunction is. Only when we are doing, non-cardiac cases in place where you don't have facility of echo and all that, or you just see a 2D echo report, plain 2D echo report, you should get alerted only when you have a normal systolic function written on normal everything. But diastolic dysfunction 1, maybe grade 1, you must go by symptoms of the patient. The patient has symptoms like breathlessness, simple breathlessness, even when he has a normal LV function, that should be enough for the anesthetist to think of doing further testing on these patients. So, hello.
Yes,
sorry. So any 2D echo report with normal LV function, patient is breathless. Basic breathlessness is a basic symptom that patient will give you, or is not able to lie flat. That should be enough to get him investigated further. So that's the only thing practically I can think of as of now about diastolic dysfunction grade 1 especially. And newer machines nowadays, they give you automatic calculations, and they will give you automatic reports where you will have a systolic function of say 48.5% or 47%. So these are all automatic functions of the machines. That's why we are getting more and more of these grade diastolic dysfunction grade 1. But we should go by symptoms of the patients, I feel. So that's it. I think that's what I wanted to say about this. Manisha?
Okay, thank you. Thank you very much, sir.
Thank you so much, sir. Thank you.
For this practical inputs. So it was a great deliberation by our all 4 participants, Dr. Sheetal ma'am, Manjari ma'am, Dr. Deepak, Dr. Samrat. Thank you very much. It was there for their nice presentation and beautiful slides also. I also thanks to Dr. Vijay Shetty sir and Dr. Uday Gandhi sir for moderating today's session and for their practical inputs. Thank you very much. This meeting is over.
Thank you very much. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, ma'am.
Thank you so much, Dr. Uday, Dr. Vijay, and all the speakers, Dr. Samrat, Dr. Deepak, Dr. Manjiri, and Dr. Sheetal. Thank you all. Thanks.
Thank you, madam.
Thank you. We will end the meeting.
Yes.
Yes.